delivery details and maternal and neonatal complications. The statistical analysis was done by using SPSS version 16. Independent sample t-test and Mann-Whitney U-test were used to compare continuous variables, and chi-square test or Fisher test for categorical variables. The ROC curves were used to identify cutoff value of SII and NLR for predicting the likelihood of developing PPROM, and the D-long test was used to compare their predictive ability. P-value less than 0.05 was considered statistically significant. So to my main results, most of the women were in the age group of 26 to 30 years, and most of them were primary gravid patients. After considering the inclusion and exclusion criteria, we had 242 women, out of which 35, that is 14.5% women, developed PPROM and were classified as PPROM group, and remaining 207, that is 85.5% women, were classified as control group. So when we compared the baseline demographic characteristics between the two groups, such as the maternal age, occupation, socioeconomic status, and the gravid status, we did not find any significant difference, hence ensuring a fair comparison. Approximately 91% of patients in the PPROM group delivered prematurely, and 1/3 of them required induction of labor, which was significantly more when compared to the control group. However, the cesarean section rate did not differ significantly between these two groups. Both NLR and SII were significantly raised in patients who had developed PPROM. On the right side, we see the box and whisker analysis, which shows a higher median and a wider distribution for both NLR and SII in the PPROM group. The boxes are also situated higher, which shows a higher inflammatory response, and the wide separation denotes the statistically significant difference between the two groups. The ROC analysis was used to understand the predictive ability of these two indices for occurrence of PPROM. SII showed a little better discriminative ability with area under curve of 0.821 when compared to NLR with AUC of 0.766. However, both these values were significant and making them a good and acceptable predictors respectively. We also used the analysis to find the optimal cutoff. A cutoff of 924.7 for SII and for NLR 4.4 was derived. At this cutoff, the sensitivity of SII was 82.9%, and for NLR it was 60%, and the specificity was 69.1 and 74.9% respectively. Although the sensitivity of SII was slightly better than NLR, when we applied the D-long test to compare their predictive ability, we did not find any statistically significant difference, hence making them comparable predictive indicators. We studied the complications for the two groups. The major maternal complications seen were antepartum hemorrhage, cord prolapse, PPH, SSI, and fever. And the major neonatal complications requiring NICU admissions were prematurity and respiratory distress syndrome. When we compared these complications between the two groups, the maternal complications did not vary significantly between the groups. However, females with PPROM had significantly more neonatal complications when compared to the control group. Both SII and NLR were raised in patients who had maternal complications, but the ROC analysis showed limited predictive ability for maternal complications. Similarly, the ROC analysis showed limited predictive ability for predicting neonatal complications. So the prevalence of PPROM in my study was 14.5%. It has ranged from 19.2 to 42% in various studies. We saw that mean SII and NLR were significantly elevated in the PPROM group, showing that subclinical inflammations precedes clinical rupture, and that these indices can be used for prediction of PPROM. We have compared our study to few available literature who have also shown that these indices can be used for predicting PPROM before rupture. Some studies have also shown that NLR and SII at higher cutoff values can predict adverse neonatal outcomes. So the key relevance of this study is that simple and practical tests like CVC can be used for early risk identification, closer surveillance, preventive measures, improved counseling, and shared decision making, which will cause a paradigm shift from reactive management to proactive risk stratification and prevention. The study was limited by a single center design. We also did not establish any definitive cutoff for predicting maternal and neonatal complications. So further large-scale multicentric studies are needed to validate these findings. So to conclude, Both SII and NLR measured in second trimester are significantly elevated in pregnancies complicated by PPROM and can serve as potential predictors and useful biomarkers for identifying patients at risk for PPROM. These are my references. Thank you.
So we now invite any questions if.
Hello, good morning all.
Two questions.
Myself Dr. R.K. Gautam from Bokaro. Although I'm not a gynecologist, but two short queries are there. First thing, is inflammation as a primary etiological cause or secondary to membrane rupture? And second, you are using NLR in your study. So, can you differentiate between the physiological leukocytosis versus pathological? These are my short queries.
Yes, sir. So for the first question, yes, the inflammation is believed to precede the rupture of membrane. It will, after the rupture occurs, it increases, but the basic pathology is still believed to be a chronic indolent inflammation that we are trying to detect early so that we can have a risk stratified screening process for these women.
So it could be primary as well as secondary.
No, primary is there. After the rupture occurs, there is a higher chance of having a ascending infection. That's a different thing.
Okay.
But the chronic inflammation is one of the causes of PPROM, etiology. And coming to your second question, yes, physiologically NLR is raised. That is why we have chosen the second trimester, which is the most immunologically quiet trimester if you see during pregnancy. And we have also ruled out any other factors, confounding factors, which may also increase NLR to our best of abilities, like a recent illness or trauma or any procedures. So, and that is why the ROC, we are also not depending on a causal attribution. We are seeing statistically, we have found the cutoff above which we say that this is higher in PPROM patients.
Okay, thank you.
Any other question? Okay, thank you.
Thank you, Dr. Anisha Chaudhary. Now I call Dr. Chinni Krishna Kasi for ultrasound evaluation for upper airway. Dr. Chinni Prakash from Rourkela Steel Plant.
Present.
Good morning, respected colleagues. Greetings from Ispat General Hospital, Rourkela. In anesthesia, new technologies frequently promise improved safety and efficiency. Yet, their routine clinical usefulness often remains uncertain. Ultrasound is one such evolving tool in airway assessment. In this study, we evaluated its role in preoperative airway evaluation and attempted to answer a key question, that is, does ultrasound truly make a difference? Let me begin by adding context to my dear non-anesthetist colleagues and explain why is airway to be examined in the first place. Imagine a house is on fire. The firemen rush in, ready to rescue the occupants, only to find that the main door is locked with a heavy iron shutter. Their usual tools don't work now, and their usual plan won't work. Had they come prepared, they could have brought the right tools to open the door safely and manage the fire efficiently and in time. Similarly, if an anesthetist can identify difficult airway beforehand, they can come prepared with the right equipment and strategy and significantly reduce the risk of critical mishap. And that is why airway is to be examined in the first place. Now, how is airway examined? Traditionally, we rely on conventional clinical tests like Mallampati grading, thyrometric distance, etc. These methods have been in use for several decades and are simple, quick, and bedside friendly. However, despite careful conventional assessment, unanticipated difficult airway is still not uncommon to be found on operating table. This highlights an important limitation of conventional tests, that is, conventional tests are subjective. They assess the external anatomy, while difficulty often arises from the internal airway structures. To overcome these limitations, newer modalities of airway assessment have been explored, and among them, ultrasound-based airway evaluation is prominent. Ultrasound offers several advantages, but also, as shown on the right side of the slide, ultrasound airway assessment has multiple measurable parameters: hyomental distances, ratios, pre-epiglottic space, epiglottis vocal cord distances, etc., etc. The challenge with ultrasound now becomes the complexity of performing it. There are just too many parameters, and their clinical relevance is still understudied. Hence, we started with the following problem statement: that the multiple ultrasonographic parameters have been described in airway assessment. Comprehensive ultrasound evaluation may increase the preoperative assessment time, and uncertainty exists regarding which parameters are clinically useful. We aimed to evaluate whether preoperative airway ultrasound can predict difficult laryngoscopic view. Our primary objective was to assess its predictive ability, and secondary objectives were to study correlation with the laryngoscopic grade and compare it with the conventional airway tests. Before we go further, let me explain Cormack-Lihan grading for better comprehension. Simply put, Cormack-Lihan grading, or CL grading, describes how we see the glottis during laryngoscopy. Grade 1 is an open door or an easy airway, and grade 4 is a closed door or a difficult airway. This study was conducted at Ispat General Hospital from the July 2024 to August 2025 after obtaining ethical committee approval and consent. We first enrolled 190 elective surgery patients satisfying the inclusion criteria, and all the patients underwent routine pre-anesthetic airway assessment using standard clinical tests which were recorded for comparison. Then, preoperative airway ultrasound was performed on each patient by a senior anesthetist. This was followed by standard induction of anesthesia and laryngoscopy to assess and label the final airway status using Cormack-Lihan grading system done by a different anesthetist. Correlations between ultrasound parameters and laryngoscopy grade were analyzed using appropriate statistics and results published. These were my inclusion and exclusion criteria. Now, coming to results, this is the demographic data in my study which correlates well with the general population demographics. Coming to the core results, in the current study, 20% of the population had difficult airway as found by the airway examination during laryngoscopy at Cormack-Lihan grading. In the further slides, we'll find out how many of these difficult airways could be picked up beforehand using the different airway evaluation techniques. Now, starting with the ultrasound evaluation, these are several parameters that have been measured and compared in our study. As can be seen here, all the parameters show a difference between easy airway and difficult airway, meaning that ultrasound is in fact finding out difficult airway. However, statistically significant results were shown by only one derived parameter, that is pre-E by EVC ratio, or pre-epiglottic distance to epiglottis and vocal cord distance ratio. This table shows the predictive performance of ultrasound airway parameters using specific cutoff values that were derived using diagnostic performance analysis with Jordan's index using Cormack-Lihan 3 and 4 as reference. Now, most individual parameters show moderate sensitivity and specificity with relatively low positive predictive value. The pre-E by EVC ratio at a cutoff value of more than 0.95 turned out to be the best predictor of difficult airway. It showed highest sensitivity of 82%, specificity of 85%, and in addition to being the best negative predictive value of 94%. Even in the correlation statistics, pre-E by EVC ratio showed a distinct clinical and meaningful correlation with the difficult airway, meaning that performing this one test could be as good as evaluating rest of the ultrasound parameters. And the possible explanation for this could be, unlike individual static measurements, this ratio reflects a perfect balance between the anterior soft tissue thickness and the airway patency at the vocal cord level. Coming to our other concern of time, in our study, we found that the mean time taken for the total ultrasound airway assessment was just over 2 minutes, including the probe positioning and acquiring all the measurements. This is very feasible within the routine preoperative workflow and supports the practical applicability of airway ultrasound in everyday clinical practice. Now, how does ultrasound compare with conventional tests? Our study found out that ultrasound measures outperform the conventional tests in identifying difficult airways. The pre-E by EVC ratio shows the highest sensitivity, specificity, and accuracy. In conclusion, the ultrasonographic measurement of pre-E by EVC ratio showed significant correlation with difficult laryngoscopic view, whereas other ultrasound parameters demonstrated poor correlation with CL grade and limited predictive value. Now, coming back to the question that I began my presentation with, does ultrasound really make a difference? The answer is yes. A focused ultrasound evaluating pre-E by EVC ratio or pre-epiglottis to epiglottis vocal cord distance ratio reliably predicts the difficult airway. These are the limitations in my study. My references. Thank you.
Now he is ready to take questions.
So you mean that you have not done PSC of these patients? There was no bias.
Yes, madam. We did a routine standard PAC in all the patients before.
Malampatti grading was not done.
Yes, madam. It was done, madam. It was done.
So you were biased then? बायस तो आएगा फिर अगर आपने मलमपट्टी ग्रेडिंग किया है
yes madam
तो फिर वो बायस आएगा कॉर्मेक लेहान इज ऑन टेबल बट मलमपट्टी ग्रेडिंग इफ यू हैड डन so you know that this patient might be a case of difficult
yes
airway.
madam so we made sure that the malampatti that the a pre-operative evaluation was done by a different anesthetist and Cormac Lihan grading yes that bias
have not spoken in this
okay
so that you have to see
yes we have taken care of that
unbiased way of dealing the patient
yes
and since you said that ultrasound was done with a different anesthetist
yes ma'am
and another anesthetist has done
yes
Cormac Lihan grading
yes ma'am
and what was in difficult cases because 20% is a very high percentage
yes, even
of difficult airway
yes.
this is what I felt
yes madam
in Cormac Lihan you said it was 20%
yes madam
so you mean to say that 20% of the patients are having difficult airway
yes madam even after seeing the results we were also astonished like
even in my experience of 35 years of being an anesthetist
yes ma'am
20% cases of difficult airway
yes madam
is very high
yes
I mean I don't know I'll have to look back on my experience that how many percentage of patients did I find difficult it's not under an experienced anesthetist what was the experience of the anesthetist doing Cormac Lihan
we have an experience of minimum 8 years madam of all the anesthetists that were performed
more than 5 years I can understand
okay
Sir,
okay
if I can
yes sir please
So, good presentation Dr.
thank you sir
Yeah, carry on.
Quickly, the point is what was difficult area, how was it measured? That's one.
Okay,
Because that's a different situation.
Yes.
You can't just label it as a difficult airway. If you could just do it on a common plan 3 or 4, it's okay. That was the cutoff.
yes
The second was you had 20% difficult airway.
yes sir
How many of these subsequently were taken up as difficult airway by the ultrasound? I think that message should have come out a little clear. So you
yes
detected 20%
Yes,
by
sir.
the Cormac Lihan,
yes
and then subsequently it was followed by your ultrasound assessment.
Yes, sir.
So how many of these 20% converted to a difficult airway with the ultrasound? If you can highlight
yes sir
that.
thank you sir Alex. The first thing that you are asking the definition of yes sir we label difficult airway of a Cormac Lihan grade of more than 3 or of more than 3 was labeled as a difficult airway sir but we didn't have a definitive definition for ultrasound based difficult airway because we were planning the cutoffs from the study. So after this study, probably we can if there are substantial amount of studies, then we can come to a definition for the ultrasound. But for the study purpose, at a cutoff level of more than 0.95, there was a difficult airway, sir.
So this 20% converted to that 0.95, or how many of them converted?
Among the 20%, as can be found from the statistical analysis, all of them had a pre-EVC ratio of more than 0.95, sir. Yes.
Yeah. Thank you. Thank you.
Thank you.
Thank you, Dr. Chinni Krishna Kasi. Now I call Dr. Deepti Prabhaika, and she is going to speak on evaluating the effect evaluating the effect on chronic tobacco use on retina nerve fibers thickness using optical coherence tomography. Dr. Deepti.
Good morning, everyone. Respected chairpersons and the esteemed audience, I am Dr. Dipti and I will be speaking about evaluating the effects of chronic tobacco use on retinal nerve fiber layer thickness using optical coherence tomography. At the outset, tobacco use in Jharkhand is one of the significant public health issue. In Jharkhand, the prevalence rate of tobacco is greater than the national average. It is surprising to know that according to the GATT survey done in 2016-17, 38.9% of adults in Jharkhand use tobacco compared to the national average of 28.6%. The tobacco use in Jharkhand is primarily of a smokeless form. Compared to the smoking form, which is only 11.1%, the smokeless form is 35.4%. The most commonly used tobacco products in adults are khaini, gutkha and gul, gul is particularly notorious among the women of Jharkhand. Now before proceeding to the paper itself, let me just tell you what is OCT. OCT is optical coherence tomography. It is a non-contact imaging technology that provides us with the live histopathological images of the retina. The scan can specifically measure the thickness of RNFL, which is composed of axons of the retinal ganglion cells that form the optic nerve. The results are then presented in maps and the thickness is measured in all the 4 quadrants of the optic nerve. Then there is also a graph which compares the patient's value to the normative database. Thus, this machine can serve as an effective tool for detecting the impact of tobacco on the retinal nerve fiber layer. The study was conducted to assess the thickness of RNFL in chronic tobacco users and to correlate the degree of RNFL thinning with the severity of tobacco use. It was a case control study. We took 90 eyes from 45 tobacco users and 90 eyes from 45 age and gender matched healthy controls from our OPD. From July 2024 to July 2025, participants who had a history of chewing tobacco for at least 10 years were taken up for the study. We used a scale that is a Fagerstrom nicotine dependence scale for assessing the tobacco addiction. Earlier this scale was used for assessing the addiction towards cigarette. Age and gender matched individuals were taken as control. A comprehensive ophthalmic examination was done. Fundus photography and perimetry was done. We measured the RNFL thickness with the SDOCT in our department. A signal strength of 6 or more were taken as acceptable scan. At least 3 scans were taken and all the thickness in all the 4 quadrants were noted. Persons who had previous history of trauma, severe neurological disorders, glaucoma patients, history of ATT drugs and alcohol consumptions were excluded from the study. All these conditions have shown to have RNFL thinning. Also persons who had dense cataract where we cannot take reliable OCT pictures were also excluded from the study. 42% of the participants were female and 58% were male. Majority of the age group were from 40 to 50 years. Then when we calculated the FTND scores of greater than 5 were present among the males. Gutka was the most prevalent type of tobacco among the males and gul was the most prevalent among the women. All the controls had best corrected visual acuity of 6/6. 12 cases had visual acuity of 6/12 with optic disc pallor, which was more marked temporally. All of them had normal color vision. Then when we compared the RNFL thickness, the superior, inferior and temporal quadrants show statistically significant thinning of the RNFL layer. Then we analyzed the years of tobacco use with the thinning. We noticed that as the years of tobacco use increases, the RNFL thinning was also greater and this was present in both the male and female. We calculated the odds ratio, and to our surprise, it came up to be as high as 10. Thus, a strong positive correlation was established. Compared to only 16.7% of the control, 66.7% of the cases had RNFL thinning. Then, now coming to the mechanism involved in chronic tobacco use, there are three main mechanisms. First is that the direct exposure to cyanide, which acts as a neurotoxin, and free radicals present in the tobacco impairs the mitochondrial respiratory cycle, leading to the decrease of ATP. This thus causes a direct damage to the high metabolic P ganglion cell axons of the papillomacular bundle. Second is the synergistic effect of the chronic tobacco use with the metabolic deficiency of vitamin B12 and folate lead to an accumulation of a substance called the formic acid, which leads to the demyelination of the nerve axons. Third is that the nicotine present in some forms such as the cigars causes indirect ischemic optic nerve damage due to the vasoconstrictive effect and reduction in blood flow. So we know that tobacco causes toxic optic neuropathy. So why is this study relevant at all? First, note many studies are there which actually can quantify how much RNFL loss is happening. Here we have an instrument which not only measures the amount of RNFL loss but also can tell us in which quadrant the RNFL loss is occurring. Two studies recently have been done in 2014 by Shashi et al. Who measured the effect of chronic alcohol and tobacco use on RNFL layer, and more recently by Lipika et al. In 2024 who evaluated the effect of tobacco use on RNFL layer and showed statistically significant thinning. Second is important finding is that in this study only few cases had optic disc pallor in their fundus, and almost everybody had normal visual acuity. But to our surprise, in the OCT we found out that they had statistically significant RNFL thinning, which means that OCT can serve as a valuable screening tool before the irreversible visual loss sets in. Third is the untold, unreported story of the smokeless form of tobacco. Now the smokeless form such as the gul is so prevalent among the women of Jharkhand, which to take it as a one-shot remedy for various disorders starting from tooth to bowel disorders, but this is on the contrary acting as a slow poison to the optic nerve and causing irreversible vision loss. This was an interesting case. This was my patient who came to me for cataract surgery. He had 25 years of tobacco use. His son is even showing the tobacco packet in his coat. One can see that he has so much optic disc pallor, and OCT there is so much thinning. So concluding, I would say that OCT can be used as an important screening tool among chronic tobacco users, and one should advocate for quitting tobacco use to protect vision. I strongly recommend breaking the myth of gul present in this part of the country, which is taken as a panacea of all troubles. And there is, last but not least, there is a need for stronger government legislation against all forms of tobacco. Thank you.
House is open for 2 questions only.
What is the mean age group of the study population?
Sir, it is for mean age group is from 30. Mean age group is 40 to 50.
42. So did you? I mean, nutritional deficiency is also one of the very common causes of.
Yes, sir. That's a good question. According to normal physiologically, we lose RNFL every year from 2%. So first thing to counteract that, I took up the study design was a case control study. So if a 40-year male is taken up for the study, I am comparing it to a 40-year male, healthy control. And second is that in the OCT there is a graph which itself compares the RNFL findings to a normative database. So the confounding factors due to the age, that is ruled out. That is why I took my.
I'm saying of the nutritional deficiency. B12 and folate deficiency is very common.
Yes, sir. Yes, it's a bit.
So that is maybe they are also a co-contributing factor in your findings. That is what I wanted to just clarify. Any more questions? Okay. Next.
Thank you, Dr. Deepti. Now I call upon Dr. Himani Gupta, and she is going to speak a comparative study of hysteroscopy with ultrasonography and its correlation with histopathology in case of abnormal uterine bleeding in perimenopausal and postmenopausal female. Dr. Himani Gupta from Bhilai Steel Plant.
Good morning, respected judges, chairpersons, head of medicals, dignitaries, and my dear colleagues. I am Dr. Himani Gupta from Jail and Hospital and Research Center, Bhilai. Today, I will be presenting a very interesting study comparing hysteroscopy with ultrasonography and correlation of the findings with histopathology in cases of abnormal uterine bleeding in peri and postmenopausal females. Abnormal uterine bleeding is defined as bleeding outside the normal menstrual pattern in terms of regularity, frequency, duration or amount. AUB is more than just a clinical complaint. It is a significant quality of life issue affecting up to 50% of the perimenopausal women. In this age group, our primary concern is always early detection of pre-malignant or malignant endometrial pathology. In India, the prevalence of AUB has been reported as 17.9%. To standardize our approach for diagnosis, we use the FIGO palm coin classification, which divides causes into two categories. Palm coin is an acronym where palm stands for structural and coin stands for functional causes. In palm coin, P stands for polyp, A for adenomyosis, L for leiomyoma or fibroid, M for malignancy, C stands for coagulopathy, O for ovulatory causes, E for endometrial, I for iatrogenic and N for not otherwise specified causes. Our diagnostic challenge is choosing the right tool for the right patient. Transabdominal ultrasonography remains our first line due to its accessibility, acceptability and non-invasiveness. However, hysteroscopy offers the advantage of direct visualization and targeted biopsy. Ultimately, histopathology remains our gold standard for a definitive diagnosis. Hence, with the aim and objectives to evaluate the role of ultrasonography and hysteroscopy in diagnosing a case of AUB, to correlate the findings with histopathology, and to compare the diagnostic efficacy of the two modalities, we conducted a hospital-based prospective observational study at our hospital for over a period of 18 months. We focused on women of 40 to 65 years, women having pelvic infections, pregnancy, those who were on drugs which could lead to bleeding, or those who had other causes of bleeding per vaginum were excluded from our study. Though from the reference study, the minimum sample size was 58, we could recruit 95 cases to increase the power of our study and to avoid the loss of data due to loss to follow-up. Every patient underwent a thorough clinical examination followed by transabdominal ultrasonography. Hysteroscopy was performed under anesthesia with biopsies taken from any suspicious areas for histopathological correlation. We observed that majority of our patients, that is 58% were perimenopausal, between the age group of 41 to 50 years. Their most common chief complaints were postmenopausal bleeding and heavy menstrual bleeding, closely followed by frequent menses. On abdominal ultrasonography, hysteroscopy and histopathology, polyp was the most common diagnosis, followed by proliferative endometrium, atrophic endometrium and endometrial hyperplasia. On comparing the two modalities, we observed that while hysteroscopy could diagnose all the polyp cases, ultrasonography diagnosed almost all hyperplasia cases and all the atrophic endometrial cases. On further evaluation of diagnostic performance, it showed that hysteroscopy was highly effective in identifying endometrial polyps, achieving 100% sensitivity and specificity. Ultrasonography in comparison identified these lesions with a sensitivity of 84%, indicating lower accuracy for focal intracavitary pathology. In cases of uterine fibroids, both imaging techniques detected all cases showing complete sensitivity, However, hysteroscopy demonstrated marginally higher specificity of 95%, reflecting better characterization of intracavitary extension. For endometrial hyperplasia, ultrasonography showed greater diagnostic accuracy than the hysteroscopy, which was only 90%, suggesting improved detection of diffuse endometrial involvement through imaging assessment. In cases of atrophic endometrium, both the modalities achieved complete sensitivity. Nevertheless, ultrasound showed superior specificity when compared to hysteroscopic evaluation. Overall, hysteroscopy provided a better diagnostic yield for focal endometrial lesions, and ultrasonography was better for diagnosing global endometrial changes. In cases of endometrial carcinoma, which were 3 in our group, ultrasonography actually performed with 100% sensitivity and specificity. Our findings closely align with the global literature. For instance, our 100% sensitivity of hysteroscopy for polyps mirrors the results of study by Nita et al. And also for fibroids, our sensitivity of hysteroscopy was 100%, which is similar to that of the studies by Aisha Razak et al. And Alema et al. Hence, to summarize, AUP is the most common gynecological problem of peri and postmenopausal women. Ultrasonography is good for initial screening, but hysteroscopy gives a better visualization of endometrial pathology. However, it is important to note that hysteroscopy is always operator dependent. Without adequate expertise and experience, subtle signs of chronic endometritis or early focal carcinoma can be misjudged. In conclusion, we can say that transabdominal ultrasonography remains an excellent, cost-effective first-line screening tool. However, hysteroscopy is superior for detecting polyps and submucosal fibroids. For the most accurate management of abnormal uterine bleeding in perimenopausal and postmenopausal women, we recommend a triple approach, that is, initial ultrasound screening, followed by hysteroscopy with guided biopsy and histopathology for a definitive diagnosis. Thank you.
She can take questions now.
I'm Dr. Alokananda from Tata Main Hospital. Very good presentation. I have a few questions for you. First is, what was new in your study? Second, how you could say with 100% sensitivity and specificity that ultrasound can diagnose malignancy? And third is that why you have not opted for transvaginal ultrasonography and why you performed only transabdominal?
Thank you, Aloka Bab, for the questions. Regarding your first question, there is not much new in our study, but since medicine is an evidence-based approach, so it is an evolving science, and every new study adds to the original ones. So in our study population, this kind of study had not been done. So if the generalized approach is equivalent for our population, we could diagnose that. And for your second question, it was whether 100% sensitivity, because I was comparing hysteroscopy with ultrasound. We missed the early, because it was an early carcinoma changes. Ultrasound diagnosed the carcinoma changes. Ultrasound gave it as possibility of malignancy, but on hysteroscopy we could not identify, maybe because of the lack of experience in detecting early carcinoma, we could not diagnose those. So that is why I'm saying with 100% sensitivity. And for the third question, you said why transvaginal ultrasound could have been a better option, but in our setting it is very difficult to convince you as a gynecologist, maybe knowing it is very difficult to convince people for pap smear and gynecological examination, so they don't want to undergo transvaginal ultrasonography only for single or 2 episodes of vaginal bleeding. So transabdominal ultrasonography is an initial screening. That is why I use. Thank you.
Thank you.
Thank you, Dr. Himani. Our next speaker is Dr. Jitin Pandey from ISCO, Banpur, and he is going to speak on opioid-free anesthesia, a new paradigm. Dr. Jitendra Pandey.
देख लेते हैं. Good morning, everyone. In our hospital, a septuagenarian female who underwent laparotomy under opioid-based anesthesia with 100 microgram of fentanyl preoperatively and 2 doses of butorphanol 2 hours apart. After uneventful 8 hours, she underwent respiratory depression, invited post-op ventilation, leading to ventilator-associated pneumonia, which got the discharge in her delay in her discharge for 8 days. This was not the end of the story, but the beginning of our topic. Respected chairperson, judges, and delegates, my topic of discussion is opioid-free anesthesia, a weapon in enhanced recovery after surgery protocol. Anesthesia has never opted for one-size-fits-all regime, and that's why, with the continuous modeling and remodeling, it has got the place where it is today. The current study is a combination of easily available drug, which is apart from opioids, gives a better satisfaction regarding analgesia, better hemodynamic stability, and post-operative recovery. Coming to the problem, we all know about the opioid epidemics. Since 1990, there is an exponential increase in opioid use, misuse, and overuse in developed country, and it has extended to India also, as evidenced from the films like Urta Punjab. More than 1 million plus death occurs globally, out of which 40% is prescription opioids. This is the US FDA report, which says that more than 2 million people are coming under the grip of opioids globally every year. Yet our pharmaceutical company kept on assuring in favor of opioids, just like pizza company, which says that it's your genetic, not the pizza, responsible for your weight gain. So coming to the direct from the textbook, and we know from our experience that nausea, vomiting, skeletal muscle rigidity, smooth muscle spasm, constipation, urinary retention are the side effects of opioids, but the most dangerous are respiratory depression and hyperalgesia. Hyperalgesia is there with the newer semisynthetic like fentanyl and remifentanil. Now, being the cornerstone of anesthesia, opioid was never thought to be indispensable. But down the line, the alternative approach came. So no one is indispensable, so is our opioids. Barry Fradberg came up with the concept of opioid-free anesthesia since 1990 with no much anesthesia, no less anesthesia, through measuring the brain, preemptive the pain, and emetics abstain. Opioid-free anesthesia is a new paradigm shift. It's a technique in anesthesia portfolio with simple cocktails of drug without opioids. Common myths regarding OFA: improper analgesia, need multiple infusion, expensive. The answer to all this is big no. Opioid-free anesthesia encircles the anesthesia circle in the same way like opioids, like hypnosis, sympatholysis, amnesia, hemodynamic stability, immobility, neuromuscular blockage. Our armamentarium alternative to opioids are lidocaine, paracetamol, propofol, ketamine, all benzodiazepine, dexamethasone, magnesium sulfate, muscle relaxants, dexmedetomidine, etc. Now coming along with the paracetamol, which is our friend philosopher guide, lidocaine and the miracle mineral magnesium sulfate with dexamethasone, we got that all have got the property of analgesia, anti-inflammation, and adjuvant to the opioid sparing effect. Dexamethasone has got anti-emetic effect, anti-shivering is shared with the magnesium sulfate, anti-arrhythmic, action is there in lidocaine and magnesium sulfate, and magnesium sulfate is there for antihypertensive, bronchodilation, anti-seizure, antacid, mild sedation. Our study aims to evaluate the analgesia, hyperalgesia, reduction in PONV, citizen score, hemodynamic parameter, respiratory depression. It was a 2-year study, informed written consent taken, committee with the ethics committee approval. We have included all the surgeries under GA, age 30 to 70 years, ASA 1 to 2 with normal BMI, ASA 3 or more excluded, major organ dysfunction, allergies, contraindication to specific drugs, and smoking, all were excluded. This is the flow chart which says that we have monitored till the discharge of the patient. In consent diagram, we can see that 80 in each limb which has been analyzed, and there were no left out. This is the general anesthesia protocol. You can see that in place of fentanyl and buterphenol, we have used injection paracetamol, magnesium sulfate, loxicard, and 30 minutes before the surgery, we have used injection diclofenac. The parameters, preoperative parameter, cardiorespiratory response during intubation, emergence time, recovery profile, NRS score, and incidence of post-operative nausea and vomiting. Both the groups are demographically equal, similar. We have observed with unpaired t-test and software versus SPSS version 22 was used. And this is the result, which says that analgesia and change in hemodynamic on intubation are more or less similar, but hyperalgesia, PONV, respiratory depression, bradycardia, hypertension, etc. have got significant difference from the opioid-based anesthesia. Coming to the discussion part, initiation of drug before surgery prevents the establishment of central sensitization evoked by the surgical stimulus. This is the concept behind preemptive analgesia. Zio et al. Has shown the same with the use of dexmedetomidine and loxicard infusion. We have also got its 3 versus 8 as far as the hyperalgesia is concerned. Analgesia profile was similar. Mormon et al. Has shown that PONV incidence is very less. In our case also it was 12 versus 35. Both the cases were hemodynamically stable, opioid based as well as opioid free, like the study of Tyson. Rodnick et al. Has shown that emergence time was less. In our case, it was 8 minutes versus 16 minutes average. Early enteral feeding was there with our study also, like the study of Urvoy. First stool time, it was 1.5 days versus 2.6 days. Reduced length of hospital stay, there were no difference because of the fact we have used only ASA 1 and 2 group. Concluding the fact OFA aims to enhance optimal perioperative analgesia through reducing pain score. It enables for early mobilization and patient greater satisfaction. So let's start OFA without any hesitation. Limitations of the study, more robust randomized control trial would be required. It can be used in the chronic pain also. These are my references. My acknowledgement to our team. During the demonstration, first demonstration of ether anesthesia, John Warren, the surgeon, told, gentlemen, this is no humbug. From this stage, we are now able to say the same. Opioid-free anesthesia is no humbug. Thank you.
House is open for 2 questions only.
Myself, Dr. Manoranjan.
So,
the alternatives what they have used in place of opioids also do have some side effects. They have been studied.
Yeah, actually, all the medicines have got side effects. There is no medicine in the world which has got no side effects.
So one case of depression and this drug problem
are
not
there with the magnesium
preventing to
sulfate,
use opioids. You can use it in optimal way. It's not that overdose will create all those problems.
Actually, opioids are very good, and that's why many anesthetists hesitate to leave opioids. And there were very few studies regarding opioid-free anesthesia and opioid-sparing anesthesia. Opioid-sparing anesthesia is the anesthesia when in post-operative, if required, opioid can be used. That is termed as opioid-sparing anesthesia. Our study is completely opioid-free anesthesia. Because of the fact that opioid-free anesthesia, we are using these medicines actually. Paracetamol, lidocaine, magnesium sulfate, dexamethasone, these are all. All have got some side effects, but you will have to optimally use it, and the dangerous side effects of opioids like your respiratory depression, hyperalgesia, biliary spasm, etc. are not there in magnesium sulfate 2, because 160%, 80% magnesium sulfate, they haven't got the even one case of respiratory depression, because we use only
No,
2
no,
gram.
it will not have respiratory depression, but dexamethasone have some sugar problems.
Sugar, yes, sir. Now coming to the dexamethasone.
HPA
One
axis
dose of
suppression.
dexamethasone is never going to elevate your sugar. One dose of dexamethasone is never going to start the inflammation, or depress the inflammation. Okay, sir?
HPA axis, all those things are there.
No,
It's
actually,
not,
definitely. We are in
See,
place.
nowadays
Thank you.
the
Yes, sir. Yes, ma'am.
basic concept is a balanced anesthesia technique.
Yes, sir. Balanced anesthesia balloon.
See, we are
Since
all following
1956.
that. The patients you have covered is from 30 to 70 years of age. Now those ASA grade 1 and 2.
Yes, sir.
So 2 might be having so many of comorbidities. Now seeing that whatever are the comorbidities, you have to give anesthesia as per a 30-year-old and a 70-year-old can't be compared in anesthesia.
Yes, ma'am. Coming to that
30-year-old
answer.
may not be having any
Coming to the
comorbid.
answer
So
from
if you
this
give
slide.
dexamethasone of a patient who is a chronic diabetic and a chronic hypertensive, it is better not to give that drug.
Yes,
Why
ma'am,
not
I'm coming to that
give
slide.
palbociclib or ondansetron?
I am coming to that
That is
slide.
what I am saying.
Sorry.
So you can always, you have to juggle with your drugs and then give a balanced anesthesia technique. Whether you give opioid, judiciously use, no opioids, that is your choice. You can even include blocks also in this.
Right, ma'am. You are right.
That is one of
But,
the techniques which I favor is giving blocks so that you are sparing opioids in these
okay,
old patients.
giving block might be a bias, ma'am. It might be a confounding factor, and that's why we avoided in this study. Whether my study aimed to compare opioid-free anesthesia versus opioid-based anesthesia, there were no block given to all 160 patients.
We agree for all that because
Okay,
everybody is practicing in the same way so that the
This was
outcome of
research paper,
with the concept of daycare anesthesia coming on, so many things are the pressure on the
Yes, yes,
anesthetist
ma'am.
to make the patient's recovery as fast as possible. So
We
the
cannot
concept of
discharge
opioid-free
the patient
anesthesia
after
has
giving
been there.
butorphanol or fentanyl.
Okay. Quickly, we can take very short. Be very short.
sir.
Yeah.
Very nice presentation, sir. Myself, Dr. Nilesh.
Thank you so much.
Sir, you mentioned 30 to 70 year of both people were included, 30 years of age and 70 years of age, and you standardized the magnesium sulfate dose to 2 gram.
No, actually, yes, 2 grams.
So
It
can
is
we
20
give same
It
dose
is
to a
not for the
70-year-old?
age, ma'am. Sir, it is not for the age, it is for the weight actually. It is 25 milligram per kg body weight to 50 milligram per kg body weight and adjusted accordingly. Now, a person of 70 years can be physiologically of 30 years. A person of
That is
35
very
years
true,
can
sir.
be physiologically of 70 years.
But it was mentioned in slide 2 grams. It could have been mentioned as
Yeah.
20 to 50 grams. That
Yes.
would have been better.
Okay.
It could have
Okay.
been.
Thank you,
It could
Okay.
have been.
Chalo. Thank you.
sir. Thank you, sir.
Thank you, Dr. Jiten Pandey. And our next speaker is Dr. Priyansh Sahu from Durgapur Steel Plant. And he is going to speak on clinico-radiological outcome of Indo button in joint reconstruction using endogenous technique, a comparative study. Dr. Priyansh Sahu.
Good morning to one and all, respected chairperson, reverend judges. Dear colleagues and my seniors, my paper will dwell upon a comparative study of various cases managed by plate and screws versus use of indigenous endobottoms for joint reconstruction. Superior results and cost effectiveness have been shown with the endobottom. To begin with, what is an endobottom? Let's jot down a brief history for it. The endobottom is a titanium button-like fixation device which was developed for securely fixing ACL grafts through minimal invasive approaches, also called as arthroscopy. It is placed on either side of the bone tunnels along with graft as shown here, and then flipped or toggled on the outside, creating a strong and stable fixation by holding the graft against the bone. This method helps in avoiding a second incision and eliminating some complications associated with other fixation methods like interference screws. Dear colleagues, as we move on, we'll see other holistic approaches of endobottoms. Now, what are the mechanics? To begin with, Our endobottom has various advantages over conventional fasting techniques like screws as staples. It lowers the possibility of graft slippage. Because of the aerodynamics, there is more contact between the graft and the bone tunnel, which aids in stabilizing and healing. The button-shaped design of the endobottom also helps to better healing outcomes. It decreases stress concentration on the graft by dispersing pressures over a greater area. It allows for proper tensioning of the graft, approximation of fracture segments, especially suitable for longitudinal fractures, addresses diastasis, and reduces the usage of plates and screws. However, it might not be suitable in fractures with rotational issues. Our aims and objectives were pretty simple: to evaluate and assess, compare results using endobottom with other traditional methods of orthopedic devices like suture anchors, orthopedic plates and screws, which was done for acromioclavicular joint injuries, ankle syndesmotic injuries, clinically, radiologically, and functionally. Yes, proper consent was taken from all the patients before surgery. The study period was 1.5 years from June 2024 till December 2025. There were 100 subjects, 84 males and 16 females. The average duration was 12 months. The pre and post surgical American Orthopedic Foot and Ankle Society scores and Constant Murley shoulder scores, together with reported complications and post-operative radiological analysis, were assessed. All males and females between 18 to 60 years were taken in the study. Closed injuries and open wounds of Gustilo-Anderson 3A, which were admitted within 48 hours of the initial insult, were taken. Here we can see one such case where we can see a Gustilo-Anderson 3A. He was also admitted to our hospital following a road traffic accident. Now, patients having immunodeficiency diseases and other comorbidities which could delay healing were excluded. Patients not willing to give consent were also excluded, and Gustilo-Anderson 3B and above were excluded. We can see in this video how the endobottom is threaded so that it is converted into a sliding mechanism to achieve secure non-slipping fixation. This was an indigenous technique where we utilized a polyester braided surgical suture jointly with double mini hole 2 plates, number 2 polygalactine 910 suture, a 4 mm drill bit together with a 15 cm long needle. This was done under image intensifier. And this is how we have devised our own sliding knock technique. Dear colleagues, we can see this is how we can appreciate the self-locking mechanism of endobottom. This itself has resulted in extreme cost reductions. For a surgical technique, it was simple. A 3 cm mini incision was made over the clavicle, medial to the acromioclavicular joint. And a 2 cm incision is made over the coracoid process, and the endobottom is passed through the coracoid process. Some examples. We can see in the first case, there is a diastasis. In the second case, we can see a completely blown out shoulder. Dear colleagues, as we can appreciate, two endobottoms sitting flush on the clavicle and on the coracoid process with near exact anatomical reduction of the joint. And this is the radiological view after 6 months. We can see a satisfactory range of motion at 6 weeks. We can see the full range of motion. The patient is happy. Complete near circumduction in all coronal and axial and sagittal planes can be seen here. One such case of Gustilo-Anderson 3A can be seen here. Again, we can see a satisfyingly improvement in range of motion thanks to our physiotherapy team. For ankle injury diastasis, if one can appreciate, we also have posterior malleus fracture here, along with a fibular fracture, medial malleus, and syndesmotic injury. For the lower extremity, standard direct lateral medial approaches were used for syndesmosis reconstruction. We can see endobottom coupled here with a plate. We can appreciate even the posterior malleus was fixed with the endobottom instead of using hardware devices. And this is an on-table scintigraphic view. Dear colleagues, we can see we are taking the ankle through a huge range of motion, lot of stress till then. We cannot see any widening of the diastasis. Endobottom sits sturdy and perfect. So we used a paired t-test, and we can see the chart simplifies the comparison of cost effectiveness, recovery time, and visual analog scale for the 3 surgical techniques based on a 5-point scale. And as evident from the images shown and further calculations, the p-value was significant. Radiologically, the acromioclavicular joint distance, medial clear space, tibiofibular clear space, and the tibiofibular overlap measurement showed a significant improvement. No cases of deep surgical infection, suture failure, knot slippage, perioperative infection, or postoperative heterotopic calcification were reported. Yes, there were complications with partial loss of reduction observed in 2 patients. One patient was plate fixation developed a superficial infection. Other patient reported mild shoulder pain at final follow-up, but it did not interfere with daily activities. Coming on to the cost, we can see a clavicle plate cost around 38,000 rupees. For the big boy of orthopedics, we use suture angle, that is 55,000. And yeah, as I work in DSP, we can see just 100 rupees per piece for the endobottom. The total implant costs around 500 rupees, GST included. So, to conclude, syndesmotic screws provide more rigid fixation, resulting in greater stability against translation and compression, while endobottom fixation offers more flexibility and allows for physiological micromotion. In terms of rotational stability, there is no significant difference between the 2 methods. On the other hand, suture anchors are very costly and not easily affordable by the general Indian population. To conclude, ultimately, the endobottom's advantages translate into better patient outcomes. The implant can help patients restore strength. The low risk of complications and re-injury may result in shorter recovery durations, allowing patients to resume their busy lifestyle. So, ladies and gentlemen, endobottom is extremely a better choice, affordable, low-cost solution. And with that, we come to an end. Thank you.
I'm Dr. Jayant from DMH.
Yeah.
Nice presentation. I have few observations about the study. One, the use of endobutton for the AC joint and for the syndesmotic injuries of the ankle is not new. It's something very commonly used now. Companies have endobutton already available.
So we are basically focusing on ergonomics and cost effectiveness.
Yeah, so you have compared your endobutton with suture anchors and
plates.
So suture anchors, I guess, is not the correct method for the AC joint or for the syndesmotic injuries
So
of the
depends
ankle.
on surgeons and their skills.
No, I strongly feel that for AC joint, it's a very biomechanically very demanding joint, and AC joints fail if you are going to do it with the suture anchor. Same with the syndesmosis. Now, what's unique about your endobutton, other than the cost? Okay, I understand the cost part of it. In the design part of it, what's unique in it?
Sir, we can see the aerodynamics, and as far as we studied in physics, Young's modulus of elastic strain, the surface area is less and the force we are applying is pretty much.
So that is there with all endobuttons. I mean, your endobutton, other than it being low in cost,
yeah,
what other unique feature it offers? Is it a fixed loop or it's a continuous loop?
So it's a fixed loop basically, and we are creating it inside the OT. It's not preloaded. The technique that we have used, we are using a hoop stress mechanism here, and we are using sutures, normal sutures, 910 polygalactic suture. We are making the endobuttons on table. This is cost effective, and the amount of tension that we can give is dependent, because in suture anchor we can see it's a preloaded mechanism.
So have you done any biomechanical studies about the suture metal that you have used?
Yeah, definitely, sir. It's proven. It's a polygalactic suture. It does not come out. They are like tiger sutures, and they are pretty cost effective. The MRP is around 326 something.
Okay.
Thank you.
So we come to end. One.
Thank you, Dr. Priyank Sahu. Now our next speaker is Dr. Sanjay Kumar from Vizag Steel Plant, and he is going to present a paper on a prospective analytical research to evaluate the expense and benefit of testing procalcitonin in the diagnosis of early onset neonatal sepsis. Dr. Sanjay Kumar from Vizag.
Respected chairpersons and my dear friends, I am Dr. Sanjay Kumar from Vizag Steel Plant. I will be presenting my study on the subject are prospective analytic assessors to evaluate the expenses and benefits of procalcitonin in the diagnosis of early onset sepsis. The aim is to compare between the expenses and benefits of procalcitonin testing in the diagnosis of early neonatal sepsis. The background, the incidence and etiology of early onset sepsis varies worldwide, which necessitates that antibiotic therapy be tailored in an institutional specific manner. Many diseases conditions mimic the presentation of early onset neonatal sepsis, like hypoglycemia, hypocalcemia, and many inborn errors of metabolism asphyxia. If neonatal sepsis is not distinguished from other conditions, newborn babies are exposed with prolonged antibiotic therapy unnecessarily. Total leukocyte count, absolute neutrophil count, IT ratio are not specific to bacterial infection. CRP is a good marker of inflammation, but does not distinguish between bacterial infection and other diseases. Blood culture is gold standard, but result is influenced by various factors such as prior use of antibiotics, bacterial load, sample collection, and lab standards. Procalcitonin estimation can distinguish between bacterial and non-bacterial infection and other non-infective conditions with good sensitivity and a fair specificity. This can help us prevent unnecessary use of antibiotic therapy, preventing antibiotic resistance. The present study was done in Department of Pediatrics, Visakha Steel General Hospital, Visakhapatnam for a period of 3 years from March 2017 to February 2020. Term baby more than 37-week gestation with clinical symptoms, signs, and risk factors suggestive of early onset neonatal sepsis were enrolled for the study after taking consent from parents. CBC, blood culture, CRP, serum procalcitonin were done in all patients. Serum calcitonin and CRP was repeated 72 hours after admission. Babies less than 36-week gestation, congenital anomalies, and refusal of the parents to sign consent were excluded. CSF analysis, ultrasound, and X-ray were done as indicated. Criteria for the diagnosis of early onset, this is clinical criteria: temperature, instability, skin mottling, refusal to feed, then CNS, respiratory apnea, dyspnea, lethargy, and signs for heart rate more than 180 and less than 100, capillary refill time more than 3 seconds, and respiratory and other abdominal distension. Risk factor associated with UNS: pre-labor rupture of membrane more than 24 hours, confirmed or suspect intrauterine inflammation, infection, or both, foul smelling liquor, single unclean vaginal examination during labor, prolonged labor, that is sum of first and second stage labor more than 24 hours. Sepsis screen was done and presence of 2 or more parameters was considered to be positive screen test. And these were absolute neutrophil count, immature to total neutrophil ratio, more than 0.2, micro ESR more than 15 in first hour, and C-reactive protein more than 5 milligram per liter. Procalcitonin estimation, the cutoff was 0.5 nanogram per ml. Procalcitonin and CRP were estimated twice, first at the time of admission and second 72 hours after the admission. PCT estimation was done semi-quantitatively by LSA test. This is the roadmap. Total number of patients enrolled were 100, it is not 10, sorry for this. All were subjected to sepsis scale CRP1 and CRP PCT1, that is at the time of admission, and blood culture. Sepsis screen was negative, and 2 groups were just sepsis screen negative and sepsis screen positive. In the positive group, there were blood culture positive and blood negative group. Again, as per protocol, sepsis screen negative patients were subjected to repeated sepsis screen, and those who were positive, they were enrolled in the sepsis not proven group, and those who were negative, they were regarded as no sepsis. And again, after 72 hours, that is CRP2 and PC2 was done. Results: total number of patients 100, sex ratio male 32, female 68, mean weight 3.2 kg, mean age of presentation 14 hours after birth, mode of delivery normal delivery 57, cesarean section 43. This is the clinical symptoms, and most common symptom was hypothermia followed by hyperactivity. Risk factor, that premature rupture of 38 cases, confirmed or suspected intrauterine inflammation, infection or both, that is triple I, 26, prolonged labor 18, forest penile lichen 11, and single untreated vaginal examination during labor 7. Blood culture positive 37 or 22, Klebsiella 19 cases, E. coli 11, B. streptococcus 5, and coagulous lipid staph 2. This is the most important 2-3 slide as far as this study is concerned. If you see in the sepsis group, CRP1, PCT1, and in the CRP2 group, there is not much difference between these two sepsis group, at the time of admission and after 72 hours. But if we go in the non-proven sepsis group, the PCT1 in the first, at the time of admission, 37 cases were positive, and only 5 cases were negative. But when we repeated it after 72 hours, the PCT was only 16 positive cases, and 36 turned out to be negative cases. Comparison of CRP and PCT, the sensitivity of CRP was almost same at the time of admission and after 72 hours also. The specificity decreased from 90.4 to 62%. But if you see the PCT1 and PCT2, the sensitivity increased from 82.4 to 96.8. And the specificity also increased from 72.3 to 88.7, with PPV 91.1 and NPV 99%. Early onset neurosepsis occurs with 6 to 14% incidence. Hypothermia was the most common symptom in agreement with other study like Delhi neurosepsis study. Klebsiella was the most common bacteria. This is in congruence with the study done by Jaira and Daniel. Clinical research, clinical presentation, most common presentation was respiratory distress and pneumonia. Antibiotics from 33 patients in the non-proven sepsis group were stopped. Patients were observed for 3 days and then discharged. 3 patients could not be discharged due to poor hemodynamic status. Patients were followed for next 2 months and there was no morbidity and mortality. All patients in the proven sepsis group were given 2 to 3 weeks of antibiotic with 1 mortality due to myocarditis. In agreement with the study done by Mohammed et al., the most common recognized risk factor in the study was premature rupture of membrane. PCT is not a better marker than CRP specific diagnosis of ENF because its level affected by parental factors. However, its efficacy is clear when it is repeated up to 72 hours. This is an important observation as PCT will cause positive result in the 72 hours. That 33% removed from not proven sepsis group, cost of PCT done twice was almost 7,000, but benefits was reduced stay of hospital, reduced exposure to antibiotic, prevention of antibiotic resistance, finally financial benefit and psychological solace. It is clear from previous data that PCT has moderate sensitivity, specificity and diagnosis of US. Making use of PCT in detecting and ruling out neonatal sepsis could save about 32% of the total admission days. Comparing this to the cost of test, the benefit of access to PCT is clear. Thank you.
Yeah, before we discuss, just one important thing. See, role of procalcitonin is established since last more than 20 years for sepsis. So, anything you have added new in your study?
In this study, in earlier neonatal sepsis, it has a peculiar situation in which the PCT is already increased in the newborn period in the first 72 hours, and it becomes normal after 72 hours. So if we do the PCT in the early neonatal sepsis, it may give a false positive result, very high positive result. And if we repeat after 72 hours, many false positive cases will become a true negative case. And so that we can remove antibiotic from many patients and we can save the days of stay and antibiotics.
Okay. Yes.
Yeah, thank you. Dr. Sanjay, I think good presentation. See, we know that CRP and procalcitonin are non-specific inflammatory markers, right? And more of procalcitonin, the role comes because we have to talk about the de-escalation, which you have said in your paper. But diagnosing sepsis per se using any of these individual markers is quite a difficult proposition. The CRP has to be more than 100 or the procal has to go up to 50 where the normal level is 0.5 to 0.75. So how have you correlated that? Cultures could be positive only 30% of patients. Yeah, let's complete. Just give me a second. So cultures could be positive only 30 to 40% of patients. So there are other markers, there are other reasons for these markers to go up also. So there are a lot of factors coming in together. So pinpointing straight away into this reason that no, procal has helped because the neonate it anyway goes up. I'm talking about the adult population, but you are the best expert for the neonates. So there it would come down again after a period of time. So how has it been correlated here? Maybe that needs to come out a little later.
There have been studies, various studies which have correlated it, and in FDA approval is there in America also to use this as a marker to start antibiotic or to stop antibiotic. And 0.5 is the cutoff for neonates. It has been studied. And
okay.
Thank you.
Anything? Just last question.
Good morning, Dr. Shishir from TMH Jamshedpur. So sir, as sir has already pointed out, that correlation is not clearly coming out, but what I wanted to point it out more, that how many kids underwent lumbar puncture analysis in your...
Only 2 cases.
So if the patients are already diagnosed as neonatal sepsis, you feel the need that I have to take out some more blood to get a procalcitonin done. Maybe a lumbar puncture would have straight away established the fact that yes, we have got a culture and now we need to give the antibiotics for say 14 days or till 21 days.
Rare neonatal sepsis, there are recommendations when to do.
I agree to what he has said because culture positivity means you have to do a CSF. That is the protocol.
Culture positive, what AIMS guidelines says, there are few guidelines for lumbar puncture. When the patient is culture positive, non-symptomatic with risk factor, this is the one criteria.
So with that rationale, we should not be getting done, we should not be doing one additional...
Clinical equipment should also be there. If
Okay.
you feel like, you get it.
Okay, thank you. Thank you.
Thank you, Dr. Sanjay Kumar. And we have finished. I congratulate all speakers of long paper session. They have done excellent job and they have enlightened us with their paper. And now I call Dr. Vinita Dividi ma'am. Ma'am, Dr. Vinita Dividi ma'am to come to felicitate our chairperson. Madam, please come on the stage to felicitate our chairperson, Dr. Raj Ranjan Kumar and Dr. Jayant Acharya. हाँ हाँ पीछे सर पीछे Thank you, ma'am. Thank you, sir, for chairing this session. Now our next speaker is a guest speaker from Health Ward Hospital, Dr. Devashish Sahu. He is eminent senior consultant in Department of CTVS. Sir, please come on the dais. And to chairing the session, I call Dr. Vinita Dividi and Dr. Asif Ahmed on stage. Dr. Vinita Dividi and Dr. Asif Ahmed. Dr. Devashish Sahu is going to speak on beating the clock, aortic surgery saves life. I hand over the podium to Dr. Devasi Sahu from Health World Hospital.
I think the CV slide is going to come. Huh? So, good morning, ladies and gentlemen. We welcome Dr. Sahu. Can we have the previous slide, please, regarding the next one? Yeah, he's an MCH and a DNB. He's working as a senior consultant with Health World Hospital, Asansol. And welcome here to speak on beating the clock, aortic surgery save lives. That's your topic. And I think we all are quite eager to listen to this, how it has expanded over the years and what's there in future too.
Thank you, sir, for the introduction. Respected chairpersons, respected dignitaries, a very good morning. And thank you for giving this opportunity to share our work with you. So today what I'm going to talk regarding this, it's a common thing, it's not so uncommon. Though you may feel that it is a very uncommon thing, hardly we come across such kind of thing, but it is really underreported, and the reason behind this also I'm going to narrate in this presentation. So in brief about my journey so far, it's not moving. So my journey so far, so as I said, I did my all this preliminary medical education, MBBS, MS from Orissa. Then I moved to Mumbai to do MCH. Then I have done also DNB also. Then I went for 1 year to Shanghai Pulmonary Hospital, that is considered to be the Makkah for thoracic surgery. Per day they are operating near about 100 to 130 cases per day. And I worked in some of the corporate hospitals in Chennai for almost 7 years. Then later on I moved to my own hometown, that is Bhubaneswar. I headed the department of CTVS in some hospital in Bhubaneswar. Then somehow got contact with some of the faculties here, then I moved to this place. So these are my expertise. I do cardiac surgery, both conventional way as well as minimally invasive and aortic surgery, redo surgery, vascular, thoracic, as well as the ECMO. So coming to the topic of, so what I told, this is a very famous TV actor in US. While doing some rehearsal, he died. Then we know that medical legal is a big concern in US. So what have been found out means, this is the background of my topic, because two things, any chest pain should not be considered as MI. There is also another entity exists. As the saying goes, what our mind doesn't know, our eyes cannot see. Same thing, if we don't know unaware of that entity, we may land up in the same kind of scenario. This fellow died, then autopsy done, then later on found out to be the patient is actually died of aortic dissection. But unfortunately, in the emergency room, they have given dual antiplatelet therapy. So the result will be catastrophic, because the treatment for acute myocardial infarction and aortic dissection are diagonally opposite. In our routine practice also, we have heard and we have come across such even fit individuals, the gym regulars and the person who advocates fitness also, we have heard that they died of sudden cardiac death, even they don't have time to reach to the hospital for the treatment. In India, the incidence of this aortic rupture or dissection, whatever you say, it is really underreported. That's why you don't have any comprehensive incidence data. But in UK, as you can see that the aortic dissection kills more people than the road traffic accidents. So that's why they have come out a narrative that in any kind of unexplained severe pain, think aorta. Because aortic dissection is an emergency that is often fatal when missed. And to diagnose this condition, they do CT scan for a definitive diagnosis. So, coming to our topic, means the aorta, what we are talking about, it has been regarded as the pulse of life. And the disorders of the aorta are extremely life-threatening conditions. Out of that, two common emergency situations include aortic dissection and aneurysm. Because of the advances in imaging modality, significantly the number has been growing. However, despite considerable advances in surgical treatment, still the mortality in acute phase is really high. And to diagnose this condition, there should be high index of suspicion. So what is a dissection? A dissection of an aorta happens when the pressure or weakness inside the aorta causes the layers to split and break the aortic wall. Just like think of a plywood, it will have several layers of that wooden. So same way the aorta is having the three layers. The inner side intima, then media, then adventitia. So what will happen when blood flows through that false lumen, there will be malperfusion to several organs. It can hamper the blood supply to brain, it can hamper the blood supply to the limbs, it can hamper the blood supply to the visceral organs. So it can deprive the body's organs of vital blood supply. So that's why it is a life-threatening condition that requires prompt emergency medical attention. So this is a pictorial diagram showing the stages of aortic dissection. You can see that it is, as I suggested earlier, the first picture is suggesting of that healthy vessel wall, this part. Then the first stage is there will be intimal break. Then blood is flowing through in between the layers, creating this is the true lumen, this is the false lumen. Then this is the last stage when the adventitia will be very thinned out because of this pressure and it might rupture. So this is another diagram. You can see that how videos suggesting how the dissection progresses usually. So the intimal break, now blood is flowing through that false lumen. So what is why were they so much serious about this entity? Because the natural history means if we don't treat and leave it as such, what happens? The mortality rate is almost 1% every hour for the first 48 hours. So deadly. So that's why every second counts in aortic dissection. So are all people are prone for developing all these kind of things? Definitely there are certain risk factors, like patients having connective tissue disorders like Marfan and Ehlers-Danlos, while extreme straining associated with bodybuilding, illicit drug abuse, poorly controlled high blood pressure, pregnancy in women with connective tissue disorder, smoking, atherosclerosis, trauma, and sometimes also during intervention, we can call it as iatrogenic. So the classification goes like this. Why this classification is important? As we can say, there are two modes of classification, Stanford and DBK. This type 1 particularly is an urgent situation where type B can be managed conservatively, but type 1 needs immediate attention. So how do they present? The presentation varies according to the organ that involved because of this malperfusion. So if it happens to the cerebral blood circulation, the patient might present it with lightheadedness, vision changes. If patient has having this blood supply compromised to the heart and everything, they may present with chest pain as well as shortness of breath. And similarly to the peripheries, to the limbs, it might present with tingling of hands or feet. And to the viscera, then visceral ischemia might happen, which can present just like acute abdomen. And these symptoms, usually what happens, these symptoms may be mistaken for some other conditions which can delay diagnosis and subsequent life-saving surgery. So what are the different modalities to diagnose? The routine test we do, but most important is CCT. But on our routine test also, we can get some early indication to go for that CT. Like some of the X-ray chest finding, we can get like that there will be mediastinal widening, the irregularity of aortic contour, as well as sometimes if it has more, it has ruptured or something, then we might get in some cases of hemothorax also, website. And in the echo also we can see the intimal flap. We can see that the red arrow showing that intimal flap. But definitely the CT is the gold standard to diagnose this condition. So different modalities of treatment are there. As I told, the type B kind of dissection, there equals conservative management, particularly blood pressure, because this patient will have very high blood pressure and there will be very fluctuation of this blood pressure will be quite evident. Surgically, the dissected part, the damaged part, we usually replace with a Dacron graft, as the picture shows. So that is a surgery, and some procedure also we do in an interventional manner. On some cases also it will be hybrid, means that will be a combination of both surgical as well as interventional. So now coming to our practical experiences, this is all about theories. So this is that interventional what I told you. You can see that intimal break is there. Now we will put a stent across that, so it will seal that, so blood will not flow through the false lumen, then automatically it will heal. So this is the interventional part. And why this aortic surgery is so unique in comparison to other cardiac surgeries? The mantra for aortic surgery is be alert and stay calm and expect the unexpected. Because if we know, because so many challenges, the diagnosis, the CT might depict something, but by that time the disease might have progressed further. So it is most of the time we used to get on-table surprises. So we should be ready for that to tackle that situation. So 2 cases back to back we did here in our unit in Asansol. It is called a Bentel procedure in a case of in the case of aortic dissection. This is the videos of those. So this is a initial first case is a 20-year-old boy who presented with sudden onset of chest pain. Then on routine investigation done, and in the CT also we did. So the CT, as you can see, that it is suggesting one dissection in the aortic root area, a focal dissection. So further investigation we carry out. The CT, this is the echo picture. You can see that this is the intimal flap actually in the middle part, and the dilated non-coronary sinus with severe aortic regurgitation. So what we did, we replaced. So we are measuring this aortic root, how much is the, because accordingly we have to calculate the what size of graft and other thing we will put. And the simultaneous also, because of dilated LV, there is moderate mitral regurgitation also was there. But we did not do anything, because once we fix that severe aortic regurgitation part, the LV cavity will be reduced and this part will settle. That's why we went only we fix that aortic part. So this is on opening the pericardium. All are being, though it is a first time the patient is getting operated, you can see that it is all pasted together as if we are doing it for the second time or third time. Then on routine procedure, we usually for cardiac procedure, we put the patient on cardiopulmonary bypass. So after all these things, we dissected that area. Then now we are going to replace this part with this what is called a Dacron graft. Below that there is a valve also, prosthetic valve is there. So now this is the whole thing has been changed. This is all prosthetic. Now this is that boy. The second case is a case of redo. The patient has already undergone cardiac surgery before, and also the patient is having a DTA aneurysm, descending thoracic aorta aneurysm. You see that. So here we have planned a staged procedure. First we fix this part. You can see that the dissected aortic root area. So we first fix this part, then later and after 1 year or 3 months or something, we are going to plan for the next, the endovascular stenting of the DTA aneurysm. So this is the TE images showing the severe AR with the dilated aortic root and dilated non-coronary and right coronary cusp area. The coronary sinus, as I told, it is so much dilated. You can see that there are 2 orifices actually. This is the dilated sinus. This is the main alveolar. This is the outlet, aortic outlet. So we have replaced it. This picture you can see that it is because of the redo, because we are doing it for the second time, this surgery. This is another case. We got a lady, very young lady, around 35 years. So she presented with same kind of acute chest pain and abdominal pain also. Then we did CT. You can see that the whole outer is dissected, starting from the outer root till the bifurcation area. So after doing all preliminary investigation, then we went for the procedures. So this is the this is transesophageal echo. So it is suggesting the dilated root, as well as this is the dissection flap. See the whole, as I told, it was almost rupture and content rupture, you can say. The whole pericardial cavity was filled with blood. So in this case, we replaced the whole aorta because the wall was normal. So we replaced only the aorta. This is that dissected part. As we are opening, you can see that there will be an intimal tear. The entry point will be there, through which the blood has come into that false lumen, and it is dissected circumferentially. So this is the adventitia part, and this is the media part. It has formed as if it is two layer. This is that rent. Since the wall was normal, we preserved that wall. We just replaced that dissected segment. This is, I'm testing the valve, how the valve is competent. This is called saline test of the native valve. So we have replaced both, put a graft both in the proximal end as well as distal end. Then we connected with each other. This is graft to graft anastomosis we are doing. This is the final picture. This is another case also, same kind of thing. The patient actually initially was admitted because of abdominal pain in the gastroenterology department, GI medicine department, then transferred to our side for the surgery. This is, we can see that the extension of the aortic dissection has extended up to the bifurcation. The patient presented with only with abdominal pain, no chest pain. That's why the patient initially was admitted in the gastromedicine department. This is the T images showing that flap. This is the picture, we can see that. As I told earlier, this is for brain protection. We have cannulated the carotid artery with a graft. This is on opening, we can see that there is a big hematoma over the aorta as well as hemopericardium. This is that subcapsular hematoma in that aorta, and also there is an intimal break here near the innominate artery origin. Same thing we did, resected everything. Then this is called as means separately we have attached the innominate artery lower down so that further any intervention is required, we can do it safely. So this is the final picture after procedure, the CT. Whatever you are seeing there up till here, it is the native part. It is all prosthetic up till here. This branch is also prosthetic. This is all prosthetic. So as I told, no age is spared. That you saw another 60 year. This is a only 20-year-old boy. See the size of the aneurysm, the aortic root. This patient actually initially presented with only this aneurysm. I told that you have such problem, you need a surgery. Then they denied because most of the times they will be asymptomatic. They are ignorant of their disease. It is just like a ticking bomb. Then suddenly, during a routine day of workout, just think of a situation. It's the routine, morning like while jogging and anything, suddenly he felt some kind of pain, then immediately rushed to the hospital. Then we did the procedure. This is the CT picture. It is just like one heart is sitting over another heart. So, see the aortic root. I am suggesting that it was almost the size of the aneurysm, just like the size of my palm. You can see in the second picture how it has been dissected. Then we replace that part. All dissected disease part we replaced. This is that dissected segment. You can see that very well. You can see that this is that intimal break. So this is after the procedure. Same thing also another, this is a typically a patient having marfanoid feature. Also we got with dissection, you can see that hugely dilated audicule. And it was so big that it was almost touching the sternum. In the CT you see that it is almost touching. It is gradually, this is the sternum. It is almost touching the sternum. So the whole part, as you can see that it is almost ulcerated, about to give away. Then we replace all this. So this is both ascending aorta, arch, and we debranch all the neck vessels. Means carotid, innominate, everything, subclavian. As I told, the patient is a Marfan patient. You can say the patient is falling short to accommodate the patient. Almost half of the leg is lying outside the bed. This is a risk factor actually. In Marfan patient, they landed. This is the post-op CT. You can see that everything from here till up till here, all are prosthetic. We have replaced it. This is the native part, descending thoracic aorta. This is another similar case. A patient admitted with actually chest pain. They given dual antiplatelet in some other hospital. On emergency basis, we operated this patient. You can see that dissection. This is another case for same thing, young guy who presented with dilated aortic root, and simultaneously also a dissection is there, distal to that. So we did a hybrid procedure. First we replaced this disease part, then we did one intervention later on. So this is the hybrid procedure. So we replaced this part, the disease part, then later in this part we dealt with this interventional way. You can see that there is a dissection here. So we put a stented graft over there. Since we have done already all these things, there will be a safe landing zone. The patient. This is the most aggressive form we got in one patient. This is a case of actually ruptured aneurysm. You can see that the dye has been extravasated from the abdominal aorta. Huge aneurysm. It has been ruptured actually. This is all blood. They are being compressed by this blood clot. Somehow it was holding, allowing us to get the patient into the theatre. So this is nature protecting him. So after this is a procedure, the final result, you just see that. So this is below. This part is, here it is celiac, here it is SMA. So from below SMA till bifurcation, this is aortic bifurcation, we have to replace that with a graft. This is what you are seeing, the aneurysm. It was such a hugely dilated aorta, abdominal aorta. Then we re-implanted, these are both renal arteries are being re-implanted to the neo aorta. So to conclude, as I can say that aortic emergencies, as you know, it has got a very poor prognosis, but still then there should be high index of suspicion to diagnose this condition, and the only way to save is this early detection and early surgery. Thank you.
Excellent presentation.
Thank you, ma'am.
Excellent presentation, Dr. Sahu.
Thank you.
You made it seem like it's a routine procedure for us, you know. I can imagine the pulsating, this thing in anesthetist and the surgeons being in theatre, not an easy procedure. You made it look like it is so easy. It is not so easy. I'm really, I know I'm amazed at the way you casually presented such difficult cases, and what you said is timing is perfect, and patients should reach in time to the hospital, otherwise it is very difficult to save these lives of the patient. What are the immediate post-operative complications that you see in these patients, and how long does these grafts are there in the patient for him to survive? Like suppose when does he need it again, and what are the problems associated with these graft procedures? As you have said that you have done for carotids also, and the renal perfusions in descending aorta and all. How do you take care of those parts?
Thank you, ma'am, for the appreciation. First of all, I would say that it is not only I made this looking simple, actually it is our team which has made this simple. There is a great role of paramedics as well as anesthetists. Anesthetic role is almost, I always give credit to the anesthetist for this. I say that it is 60% role of the anesthetist, 40% is of the surgeon. Because so many things to be think about and to do the particulars of the, particularly I say, as I said that in these kind of surgeries, the organ protection is very important. Particularly in some of the procedure I told you that we have to look for this brain and spinal cord protection. In other cardiac procedures, we don't care about that because blood flow is maintained to those organs. But here, sometimes we have to stop the circulation of the brain. So that's why we have to do it under deep hypothermic circulatory arrest. That is, core body temperature is 37 degree. We cool down the body temperature to 18 degrees centigrade. And sometimes also, but with that temperature also, we can operate a period within 30 minutes. That's why we have to beating the clock. Means within 30 minutes you have to do, because we know that anoxia brain cell can sustain maximum up to 3 minutes. That is with normal body temperature. But with 18 degrees centigrade, it has been studied that it can survive till at least maximum is 20 minutes. Then we can still extend up to 30 minutes. But beyond 30 minutes, it is really good. Definitely we will get some irreversible results. So to prevent that, we have adopted this strategy, what is called as selective SSCP, selective antegrade cerebral perfusion. We cannulate carotid, we give, because with low temperature we don't require a very high blood supply because the demand is low. Because hypothermic, the metabolic activity will be low. That's why we require a very less blood supply. So we continually trickle some blood flow through that conduit so that brain protection is protected. Organ means organ, visceral organ, they can sustain up to 1 hour. But brain cannot sustain up to such an extent of ischemia. Third, second thing what you told, the complications, as I told, organ perfusion is the major strategy. First is myocardial protection, how the heart is getting protected. Because it's going to be long. All this procedure, what you saw here, these are all almost more than 12 hours of surgeries. And that's why the ischemia time of the heart, how is the heart is going to, that is organ protection. Second thing is kidney protection, brain protection, all these things. And second question, what further regarding follow-up and it is not going to, the disease is not going to confine to that place only. We have replaced that. Then disease might start in the other segment. So regular follow-up, this patient we usually do regular follow-up CT scan to see further any further, suppose any area it is starting getting aneurysmal gradually, then we have to tackle it earlier. Because already the patient has developed that catastrophic situation. Third question, what you told, the graft patency, it remains with the antiplatelet drug, it remains patent, man, for lifelong. There is no, we have seen patients, man. Yeah. Not like cardiac stents, I cannot say it is cardiac. It is a fabric material, man. It's just like pant shirt, just a material. It is just a fabric material.
So, Dr. Sahu, excellent presentation. Just 2 quick points. One is, what is the cost factor involved? What would the package for doing a surgery in your hospital? Yeah. That's one. And the second one is, people recommend maybe endovascular or a hybrid model. So, do you adapt that, or quickly if you can?
As I told, sir, for a type A, surgery is the only treatment. There is no endovascular treatment for a type A dissection. For type B dissection, definitely endovascular is the first option, but some cases also it might require surgical method also. And some cases, just like I showed you one case where we have to do hybrid procedure. Means sometimes some vital organs blood supply is arising at some point. So if you put that graft there, then we are going to compromise the blood supply to the vital organ. So in that case, we shift that blood supply from that native place to some proximal point, so that the graft will get a landing zone. So this is called as debranching method. So we will debranch, we will put it into a proximal part, so that the graft, whenever we will put, it will get a safe landing zone.
Okay. And what is the package that you offer for such patients?
Package depends on the areas of involvement. Normally, just like first 2-3 cases, what we usually do, it comes around 6-7 lakhs.
That's a total complete stay operative.
Including stay, ICU stay, antibiotics, everything, including implant also.
Okay. So, one quick question from the audience, ma'am, we can? Only one question, being a guest speaker. Yeah, we can have it quickly.
Good morning, sir. Excellent videos.
Thank you.
Sir, as surgeons operating in and around Jamshedpur,
Yeah.
we just want to ask that if we diagnose a patient, that a patient is stable enough, but he is having ongoing aortic dissection,
Okay.
and we need to transport that patient, say, to Kolkata. So what are the interim measures which need to be taken to, so that we are able to ensure safe transport of that patient to a particular center?
See, the problem with this kind of patient is that is the thing, that time matters. See, as you said, the first is the patient will be very apprehensive. You have to give this opioid analgesics, anxiolytics to reduce that anxiety. Then this antihypertensives, that also we have to give. Somehow we have to keep the blood pressure around, either by NTG or nitroprusside we have to give, so that because this patient will, once the dissection will happen, we have seen that patient will have accelerated hypertension. Always, whatever you give, what kind of drug you give, the patient will, most of the time we usually prefer losartan.
So would it be a good idea that we electively intubate the patient, keep the patient on sedatives, and then
Definitely, that is the best way, I think. If you are planning for procedure, best intubate, take everything under your control. That is the best thing.
Okay, and is air transport a feasible option in such patients?
During my tenure in Chennai, we have operated a patient by airdrop. Patient was airlift from Colombo. So that has happened.
That can be done.
Yeah, that is happening. That is a routine practice also nowadays. Because of this medical claim also, they are they are covering that air ambulance charges. So now most of the big centers, they are having that helipad and they are getting those patients also.
Yeah, I think safe transportation is of paramount importance. Thank you so much, Dr. Sahu. I think it was really enchanting and very nice to go through your slides and your work that has been displayed. Excellent. Thank you from all of us.
Thank you, sir, for your lucid presentation. And I request Dr. Vinita Dwivedi ma'am and Dr. Asif Ahmed sir to felicitate our speaker, Dr. Devashish Sahu. Thank you, ma'am. Thank you, sir. Thank you, ma'am. Thank you, sir.
Thank you. Thank you, ma'am.
For chairing this session. Sorry, ma'am, actually one mistake I have done. I invite Dr. Vinita Singh, ma'am, please come over the dais to felicitate our chairperson. Sorry, ma'am. Ma'am, once again I will call you, please. Dr. Vinita Dwivedi and Dr. Asif, sir, please. I am extremely sorry for this one. I am very, very sorry, sir, for this one. Thank you, Vinit ma'am.
Thank you, ma'am.
Thank you, sir. Thank you, sir. Thank you, everyone.
Thank you.
And is our next session is panel discussion. And for this, I will call Dr. Anurag Krishna Sahai, MCH Plastic Surgery of Durgapur Steel Plant on dais, and Dr. Ajit Karmakar, Additional CMO, Durgapur Steel Plant. Please come on dais. And I will call panelists one by one. Dr. Santosh Kumar Chaube from Bokaro Steel Plant. Please come on dais. Second panelist is Dr. Anurag Krishna Sai. He is only already on the dais. Dr. Maya Bose from Rourkela Steel Plant. And Dr. Asif Ahmed from Tata Steel. Now I hand over session to Dr. Anurag Krishna Sahay and Dr. Ajit Karmakar for further proceeding.
Thank you, Dr. Patil, giving us the opportunity. As we all know, sepsis is a very important topic, and sepsis is the leading cause of mortality worldwide, and it is one of the very challenging cases across all the ICUs, be it a cardiac ICU, neuro ICU, or a general ICU. Sepsis, since 1991, there has been an effort to define sepsis and develop guidelines for sepsis. So through 1991 till 2001, then again in 2015, and then latest in 2021, there has been a different guidelines, which I know our speakers are going to delve deeply into it. And there has been some way to classify, triage the patient, starting with SIRS, then SOFA, then Q-SOFA, and now the MUSE and the NEWS. And let's see, listen to the news, and I'll start off first with our co-chairman, Dr. Anurag Krishna Sahay, to just delve upon the surgical aspect of sepsis.
Thank you, Dr. Karmakar. Now I will move from here. Good morning, everybody, and thank you very much. I have the distinguished honor of assuming a double role, both as a moderator as well as a panelist. So I have to double up, and this is what one has to do when managing sepsis. I have to show my role as a surgeon when it comes to the management of sepsis. And this is how I will do it. As soon as a patient of sepsis arrives under me, I will follow the following mnemonic, and that is, I will take blood culture, I'll monitor the urine output, I will start the patient on fluids, empirical antibiotics, take sample for measuring lactate, administer oxygen. So actually I will be taking three things, that is blood cultures, lactate measurement, and monitor the urine output, and I will be giving three, that is antibiotic, oxygen, and fluids. Then after having suspected sepsis and started him on the treatment, then I will get down to define what sepsis is. So sepsis is a life-threatening, I'll be very brief, I will not dwell into the details. Sepsis is a life-threatening organ dysfunction caused by dysregulated host response. Can be caused by bacteria, viruses, fungi, protozoa. And this can further progress from infection to a dysregulated response, which causes release of nitric oxide, and which then leads to systemic vasodilatation, and causes a systemic vascular resistance decrease. Then all this eventually goes on to reduced MAP, and that results in hypoperfusion of tissue, organ dysfunction, and multi-organ failure. And this is where this progresses to a septic shock, which I'm going to leave for my more expert panelists who will follow. Again, this also I'll skip. This also I will skip. I'll leave it for the experts. Again, I will review what I have to do. I have to do buffalo. Blood culture, urine output, fluid, antibiotics, lactate, oxygen, 3 things to give and 3 things to take. Then we will get down to the septic 1 hour bundle. I am going to leave it to my next panelists. And I will get down to what I am going to do. For me, the importance is source control. And source control is a very, very important thing. There is always a source of sepsis. And in a high situation, there is a source which has to be managed surgically. So there might be abscesses, there might be a necrotizing fasciitis, there might be a gangrenous limb, or many other places where a source can be seen. And that's where our role becomes extremely important. We have to immediately come in and drain those areas or remove those things. That's where our role is as a surgeon. And so now I am going to pass on my thing to the next panelist. Who is the next panelist?
Mr. From medicine.
Thank you.
Santosh Kumar Chaubey. Dr. Santosh Kumar Chaubey from Bokaro Institute.
Good morning, the learned audience and the moderator, sir. As sir has told it very beautifully about the sepsis, the buffalo sign and all, I will dwell on the medical management part. Sir has told the definition, it's a life-threatening organ dysfunction causing 2 things are important here, dysregulated host response that lead to acute increase in SOFA score, and there is a subset of patient arriving in hypotension. So for rapid diagnosis, we use quick SOFA score, which is respiratory rate of more than 22 breaths per minute, systolic BP of less than 100 mmHg, and ontal mental status, GCS less than 40, each carrying 1 point, and SOFA score of more than 2 lead to 13-fold, 14-fold increase in in-hospital mortality. Little bit about pathophysiology. There is a trigger, there is infection or anything, inflammation, that lead to production of cytokine, that is cytokine storm, and then the end result. Cytokine production leads to massive production of endogenous vasodilators, structural changes in endothelium, resulting in extravasation of fluid in interstitium, leading to plugging of select microvascular beds, leading to organ-specific vasoconstriction. For understanding the management, we should know the 3 things, epidemiological triad, agent, host, and environment. In agent, we have to deal whether it is a gram-positive organism or gram-negative with virulence factor, antibiotic resistance. In host response, we have to see our genetics, prior antibiotic exposure, environment, healthcare, and community. Surviving sepsis guideline has evolved through years. In 2005, we have 2 bundles, 6-hour and 24-hour bundle. In 2013, we have 2 bundles, 24-hour bundle no longer recommended. And 2021, there was only 1 bundle. 1-hour bundle, we have to measure lactate, obtain blood cultures, and administer broad spectrum antibiotics. Simultaneously, we have to administer crystalloid, which is the most important part. Not only we are resuscitating, we are managing the patient also. So, evolution of sepsis care is now 1-hour bundle. From 6-hour protocol to 1-hour AI-driven sprints. So goal is 5 intervention given in 60 minutes. From 6 hour to 1 hour. We have to manage lactate, we have to manage blood culture, we have to manage fluid resuscitation, and simultaneously we have to give vasopressors. There are many warning signs which are targeted real-time targeted warning signs that reduces the diagnosis time to more than 4 hours. And we have simultaneously, we have dynamic monitoring system like POCUS. We can use POCUS or passive leg raising. And this all thing has led to decrease in 18 to 25% of mortality. So the golden hour is 1 hour. We have to recognize, we have to stabilize, save the cell cultures, start on empiric antibiotic according to the suspected source or the use the common regimens, and then we have to reassess after 48 to 72 hours. We have to narrow down the spectrum, we have to remove the source, and the total duration of everything could be 7 to 10 days. So most important part is obtaining blood culture. Blood cultures should be given, sent to the before the antibiotic administration, and there should not be delay than 45 minutes in blood culture, in administering the blood culture, diagnosing the blood culture. For antibiotic therapy, as I have to cover the medical management part, we recommend that intravenous antibiotic therapy should be started as early as possible, generally within the first hour of recognition of septic shock and severe sepsis without septic shock. Initial empiric anti-infective therapy, active against all pathogens, and adequate source control should be done. And then we have to reassess after 24 to 48 to 72 hours. Generally, for empiric antibiotic therapy, we use in high-risk patient, you can give the MRSA coverage. For high-risk multi-drug resistant organism, we have to use 2 antimicrobial with gram-negative coverage and antifungal therapy in high-risk patients. Duration of therapy, as I have told earlier, 7 to 10 days. Sometimes longer course is required in which show slow clinical response, undrainable foci of infection, bacteremia, some fungal and viral infection, and in cases of immunological deficiencies. So, the sepsis 6, medical management, what sir were telling, buffalo, we have to see oxygen, we have to give blood culture, start on antibiotic, start on fluid challenge, monitor lactate and urine output. This is the sepsis 6, most importantly. Thanks.
Well, nicely presented, Dr. Santosh. And now? So, Dr. Maya, you have to come.
Good morning all. Thank you, Sahil sir. Pediatric sepsis bundles to talk about, it has evolved from simple time-based checklists into integrated data-driven pathways, standardizing time-sensitive actions. What do you mean by time-sensitive actions? It is the actions of initiating antimicrobials, fluids, source control, going towards quality improvement and stewardship. All have to be done at appropriate time. All of these improve marked early recognition, nevertheless the outcome. The 2024 Phoenix Sepsis Score is a validated internationally recognized tool for diagnosing pediatric sepsis and septic shock in children less than 18 years of age. The Phoenix Score does not utilize the term severe sepsis. It moves away from SIRS-based definitions which were present in 2005. Instead, it focuses on organ-based dysfunction. It utilizes age-related vital sign triggers and bedside septic screening tools. The core components include immediate and rapid recognition of sepsis and septic shock, such as altered perfusion, tachycardia, and features suggestive of sepsis, immediate assessment plus intravenous or intraosseous access within minutes, initiating antibiotics within 1 hour in case of septic shock, as soon as possible in sepsis without shock, hemodynamic resuscitation, opting for source control, monitoring, and escalation pathways. Early administration of appropriate antibiotics is the cornerstone of pediatric sepsis management. Wherever there are high resistance settings, earlier escalation to multi-drug resistant gram-negative organisms has to be done. Empiric choice should always be guided by local NICU, PICU antibiograms. Blood culture should always be obtained wherever feasible, but treatment should never be delayed. To combat antimicrobial resistance, de-escalation based on culture results and the clinical response is equally important. Crucial is the antibiotic time to first dose for audit purposes. Initial fluid resuscitation in pediatric sepsis is done using isotonic crystalloids, avoiding fluid overload in all cases. Clinical reassessment includes capillary refill time, pulse volume, heart rate, blood pressure, mental status, and urine output. Where there is fluid refractory shock, we go for inotropes. Epinephrine is preferred in cold shock, non-epinephrine in warm shock. And early referral is essential wherever advanced hemodynamic monitoring is unavailable. Because of its rapidly evolving nature, pediatric sepsis requires continuous monitoring. At places, serum lactate serial measurements is of utmost importance, but wherever the facility is not available, clinical monitoring is crucial. Early recognition of organ dysfunction allows timely escalation and referral. The organ support may be in the form of ventilation, mechanical ventilation, renal replacement therapy, ECMO, the thromboelastograms, and invasive procedures such as intraarterial blood pressure monitoring, central venous pressure monitoring, and point-of-care ultrasound. Effective sepsis management requires strong system-based implementation. Regular audits, training program, state-level and hospital-based initiatives, quality improvement initiatives, and stimulation-based education, they are crucial for improving outcomes. Presenting scenarios, a child with fever, lethargy, flu stool, persistent vomiting, poor feeding, tachycardia, tachypnea, with feeble pulses, immediately septic screen is to be done and intravenous intraosseous access has to be done. Blood cultures obtained, empirical antibiotics as per PICO protocols initiated with glucose and temperature control. In doing these, the early antibiotics with targeted therapy, with the fluid choice and the volume in the young pediatric 12-year-old patient, the bundle points are met. In another case, a 5-year-old with pneumonia, hypertension, cold extremities, after receiving 40 ml per kg of fluids, we can escalate vasoactive support, epinephrine or non-epinephrine, do an invasive monitoring, do a source control imaging. In doing this, we meet the bundle points. In a third case, where a 3-day-old infant with suspected early onset sepsis, mother with prolonged rupture of membranes and antibiotic exposure, a broad spectrum antibiotic as per NICU antibiogram is initiated with early culture and combination therapy. In doing so, with stewardship and with trial options in USEP research, we meet the bundle points. So where do we stand globally? Sepsis remains a major cause of global childhood mortality. High resource countries where there is improved recognition systems and response teams, they have better outcomes, whereas low income countries, high burden, resource constraints, using antimicrobial resistant complicates care. Where do we stand in the eastern zone? What's the data? Usually Bihar, Jharkhand and Orissa have similar statistics. We have come down 50% from an initial of 60 per 1,000 deaths to 30, which still is above the national figures of 40, which was 45 has come down to 25. We are still above the national figures. And all of these is contributed by limited access to PICU care, by delayed presentation and antimicrobial resistance. Despite all these factors, sepsis bundles are cost-effective interventions. They can reduce the mortality significantly. Also, quality initiative, improvement initiatives and local antibiogram networks also help in achieving very fast. The 2024 WHO guidance, 2020 Surviving Sepsis campaign, they have always served as informed care pathways, but everything has been revised now. The Phoenix 2024, it stands as the benchmark in pediatrics. Also, neonates with antimicrobial resistant concerns have targeted tailored antibiotic combos. Last but not the least, we have technology of multiplex, PCR, microarray, FISH, etc., which collect blood samples in 1 hour to 4 hours max and detect the pathogens, gram-positive, gram-negative bacteria, fungi. And among these, the BioFire is the only one which is available in India. Rest are all available outside the countries. And also the biomarkers such as procalcitonin, CRP, interleukin 6, 8, and lactate are essential for early diagnosis from non-infectious inflammation monitoring severity. So the bottom line is early recognition, timely execution of pediatric sepsis bundles, With rapid antibiotics, fluid resuscitation and source control saves life, reduces organ dysfunction. These are references. Thank you.
Thank you, Dr. Maya, for your excellent presentation. Now I will call on Dr. Asif Ahmed, master of the ceremony, because all the sepsis patient goes ultimately to the intensive care unit, and he has to handle various type of medical, pediatric, or any other surgical sepsis, and he has to come out with a better outcome. So now I'll call on very experienced intensivist, Dr. Asif Ahmed from Tata Main Hospital. Sir, I'll ask the timer, those who is Upayan, he has asked for 2 more minutes, so make it 8.
Okay.
Thank you. Thank you, Aismoc.
Thank you very much,
Your
sir.
mistake.
Thank you once again for the modest introduction, and good morning, ladies and gentlemen. So here we will be speaking about basically the sepsis bundle in the ICU. In fact, you might have a reiteration of this the topic that has been discussed, but I think that's important for us to register. Now, why sepsis is a concern? In fact, sepsis is a killer because we have around 11 million deaths worldwide, a death happening every 2.8 seconds, and survivors who do come about do have lifelong consequences. In fact, in the last 3-4 years, what we have seen is that the incidence of sepsis predominance has actually doubled. It's both a global as well as a local problem. In fact, amongst all the countries, the Southeast Asia, in fact, comes into the highest of the percentage where sepsis cases are present. And a recent report in the news which said that sepsis claims much more lives in India as compared to other neighboring countries. So what's our aim then? So this was put up as the 2030 Global Agenda for Sepsis. I think a lot of work is being done, and a lot of it is right up into the news too. The purpose of this whole agenda is to have the survival rate improve by another 20%. Now, who's working for it? In fact, the body called the Surviving Sepsis Campaign, which has been on right from 2002, which started with the Barcelona Summit, and it has been endorsed by the international bodies, the Society for Critical Care Medicine, that is from US, and the European Society of Critical Care Medicine again, and even the Indian Society of Critical Care Medicine has got incorporated in these guidelines. Now, what we look forward to is the most recent is still 5 years old, but that is what we are having, and that was the 2021 Surviving Sepsis Campaign guideline for management of sepsis. Sepsis management is an array of multiple factors coming together, multiple initiatives taken at the same time, and this is how it is. We don't have the time to discuss, and in fact, we would require a whole day to discuss as to how the sepsis is to be managed. But what we need to understand, and the very purpose of this panel, is to understand again the importance of time and the sepsis bundle, the 1-hour bundle. So we understand that every second matters, and that is how it is. So for the management of sepsis, we need to act right now and the right way, and that's what we need to understand here. Now, before we go on to the sepsis bundle, let's understand what a bundle is. Basically, a bundle is a set of small structured 3 to 5 evidence-based practices which, when are performed together in a particular sequence and reliably and with a timely intervention and with a timely process, these result in a better outcome rather than performing it individually. I think that's the whole purpose of having a bundle, not doing it in singularity, but in conjunction with all the parameters done in a proper sequence. So based on this, the sepsis 1-hour bundle was created, which is again a set of evidence-based time-sensitive interventions designed to reduce sepsis-related mortality, and this is to be done immediately. As already said by my preceding speakers, it's basically upon acting quickly, it is minimizing the time to treatment, you have monitoring very closely for the response and communication of the same to your subsequent doctors and a follow-up of the same patient. It comprises of standard protocols with rapid intervention, basically leading on to a reduced mortality. What started off in 2003 was a 6 and a 24-hour sepsis bundle. It has changed over to a 3 to 6-hour bundle in 2010-12. And finally, now we have the 1-hour bundle, which is to be performed, and that is the essence of sepsis management. We will not go into the detail, but as we have already heard it before, it starts with 6 steps. Basically, measure the lactate level right at the time. This needs to be done within 1 hour and to be completed by 3 hours. Obtain blood cultures, administer the antibiotics, start fluids, 30 ml per kg, that's a standard based on the predicted body weight, and you just give around 1500 over 2 to 3 hours. Apply vasopressors at the earliest so that the mean arterial pressure is more than 65, and then you remeasure the lactate and continue with the further treatment in these set of patients. So that's the sepsis bundle all about. Now, what is sepsis? You will ask, you had SIRS plus infection, as Dr. Karmakar told earlier. I think you had a definition of severe sepsis when you had a lot of intriguing signs, multi-organ failure, and you had a septic shock when patients were having hypotension along with the use of vasopressors. But I think all of it is outdated. If we are practicing medicine today, it needs to be updated, it needs to be evidence-based too. And then the current definition of sepsis is the definition 3, which talks about the life-threatening organ dysfunction with dysregulated host response. That's mostly qualitative. But how do you measure it in terms of quantity? It is basically a change in SOFA score from 0, which is normal, and an addition of 2 to any of these cases along with the presence of infection. And in fact, the septic shock takes on the measure of lactate along with the hypertension, fluid resuscitation, and the vasopressor. So we need to diagnose patients based on these guidelines and these parameters rather than just having a presumption that these patients are in sepsis or in shock. SOFA scoring has 6 parameters, not going into details. Not easy as you would think so. Is it very difficult? I would say no. Now what happens is you just have to have a SOFA calculator downloaded on your mobile. You just have to feed the parameters of these patients and you get the SOFA scoring. So it's not very difficult at all. But the question is, can sepsis be diagnosed at the time of admission when these patients have come to the ICU or the emergency? The answer is again no, and it does not happen always too. So you have 3 different situations. One is a definitive sepsis, the other one is a possible sepsis, and probable sepsis, where it could be a high probability, source not confirmed, or it could be a criteria which has all been fulfilled. Whatever be it, if you suspect or if you have a diagnosis of sepsis, any of these conditions, you just need to act immediately and the way that has been told. So the approach basically starts immediately with initial assessment and resuscitation, the ABC, and here it is where the sepsis bundle, 1-hour bundle comes into play. And then you have the different steps, the methodology, and it has to be having a high level of anticipation, appreciation, knowledge and skill, aggressive action, and a protocolized approach. The bundle again, as soon as the patient has come, any patient with shock, with lactate high, with features of sepsis, start away with this bundle within 1 hour. Check the lactate, do it with an ABG or a VBG, but you have to have the lactate levels, which is normally less than 1 millimole per liter, and anything above 2 needs to be evaluated. Blood culture, already highlighted, it has to be collected. The antibiotic timing is very important, more so in patients with shock, because you have to do it within 1 hour. We'll just discuss more details about what antibiotics to be given. IV fluids, straight away crystalloids, no albumin as a first line. And in fact, within the crystalloids also use ringalactate or a basal salt solution, and that is based on different guidelines and the recommendations, not just a presumption again. Vasopressor, we have plenty to choose from, but noradrenaline is the first choice, which has shown a lot of benefit in patients of septic shock. And then once you've done all these within that 1 hour, 3 hour period, you have to recheck the lactate. And if you find if it's still high, you need to go ahead and continue with the same bundle again, continue with the resuscitation. Another measure is the capillary refill time at the bedside. All you need to do, mostly practice for children, but now it's a good bedside measure. You just have to press the bottom of the finger, keep it pressed for 5-10 seconds, and if the blood circulation comes back within 3 seconds, it's good perfusion. Anything beyond the 3 seconds is an indicator of shock. Subsequently, once you have done this bundle, it's all about that 1st-hour bundle and the 3-hour bundle. You continue with the same assessment and the management of the patient as per the protocol, more important for the medical officers, DNBs, and anyone who wants to go through evidence-based and a proper structured follow-up of patients. And you have a plenty of array again, but these are to be done subsequently after the sepsis bundle has been taken care of. And this includes the fast hug bid. It talks about a lot of supportive parameters for all these patients, talking about early nutrition, pain relief, sedation, DVT prophylaxis, 30-degree head up, blood sugar less than 180, weaning trials, the removal of the catheters, de-escalation, as well as supportive care. So quickly, just 2 more slides on this. The compliance of the sepsis bundle is quite low. It's as low as 28%, but we need to improve it, and the gaps which are there are the knowledge and the awareness, the systemic protocols which we talk about but we do not follow, and the limitations where blood culture could not be available, IBG machine could not be available. But if we are treating patients of sepsis, this is very much a requirement. So the simple way, the way ahead would be make protocols, train your team, do frequent audits, and regularly for improvement. In fact, what we tried and what we have done in our unit is basically, you can see we have created a stamp. Apart from the first 4 steps, we have a stamp put up. It's to be put up by all the doctors who are managing patients. So once you're assisting the patient, when you're doing a clinical note, on the side, you just have to put the stamp and all the parameters are recorded. So I think this brings about a lot of ownership. So it's just to say it's possible, not so difficult, what the West and everyone has been proposing, even we need to inculcate, and let's do it together. Thank you. Thank you for the extra time, sir.
For it. excellently summarizing the whole sepsis aspect, the details of which, as you rightly said, will take a full day to discuss upon each and every aspect of it. So for audience clarification, I'll put up a question for surgical, medical and intensive care unit. Say a 56-year-old male diabetic uncontrolled with a blood sugar of more than 600 comes with shock and necrotizing fasciitis, maybe the probable cause of the infection and so on. So as a medical profession, sir, Dr. Chaube, how you are going to manage the sugar level of that patient?
Sir, this is a very nice question. Now we have two challenges. As told by sir and all the speakers, time is important. It's a time critical emergency. So here it is two challenges. One is elevated blood sugar that lead to dehydration. In HHS, about 6 to 7 liters of fluid, there is a patient is in 6 to 7 liters of deficit, and simultaneously in sepsis also, there is also a fluid deficit for which we are giving crystalloids. So here management is fluids, simultaneously start on antibiotics, send the blood culture or source from the source, pus culture you have to, from necrotizing fasciitis you are saying. So we have to give the culture from there. And then, but we should not wait for the result. We just start on resuscitation with fluids, and if MAP is less than 65 millimeter of Hg, then we have to start on inotropes also. Antibiotics, inotropes and fluids. That has to be told, and source examination. Thank you, sir.
Thank you, Dr. Chaube. Sir, Dr. Sahai, sir.
Yeah. So I will cite an example of one case which I came across, necrotizing fasciitis, but actually when I looked at it, it turned out to be, it was long lasting, so it had almost converted into dry gangrene, and the limb was looking like a charred piece of wood. So my colleagues, they said, well, since it does not have a circulation, we can simply do the cultures and follow up with the management of the sepsis. There was no urgency. But the patient did not improve. He started deteriorating. Moreover, he had refused to undergo amputation. But eventually, when he had almost landed in coma and he was about to finish off, all measures were proving futile. So we took him to the OT. And of course, there was no circulation in the limb. But we did a guillotine. And to our surprise, as soon as we had done the guillotine, the pus was there in the marrow. It came out shooting like a bullet. And on the table, within 5 minutes, the patient just got up, improved. So that is the importance of source control. That is what I want to say.
Thank you, Dr. Sahai, with a good example. Sir, Dr. Asif, sir, yes. Now you summarize the whole patient management.
Yeah. Thank you, sir. So I think once a patient comes to us, it's a very structured process that we should follow. The whole purpose of this panel is also about the sepsis bundle. So the initial assessment and your resuscitation is very important for these patients. And there comes the ABC. There is the identification of the current problem. And there is where, as soon as the patient has come to you, once you've done an airway breathing circulation assessment and the clinical signs, you immediately convert to a sepsis bundle activation. Because the resuscitation starts with basically, obviously with the two examples that you have given, both are cases of sepsis. Even if it's suspected, even if it's probable, there also we have to just go ahead with this bundle. And we have to start basically with your fluid therapy, checking of the lactate. I think standard, those 6 things have to be just and quiet. Now what is important here is the choice of antibiotics. That's again a session to be taken for the day. But I think for patients coming with necrotizing fasciitis, the correct combination would be to cover mostly gram negative, along with gram positive also, because it all depends how it is, along with the coverage of anaerobes. So I think good coverage in this situation would be covering it with the BL-BLI, that is a piperacillin tazobactam to start with. And along with that, you can have an anaerobic coverage in terms of a clindamycin, mostly because piperacillin tazobactam does cover, but metronidazole if you think that it's going to be of resistant type. MRSA coverage may be given, but I think clindamycin should be taken. But if you do not have MRSA cultures very recently in your hospital or antibiogram does not show, then we should not use it rampantly. It's only if a culture is positive, or if you start it like linezolid, then you should stop it after 48 hours so if MRSC coverage is not there. So once you've done the resuscitation, then starts your workup parallel, basically as to what are the causes, what are the underlying problems, and how do you take it forward. And there comes the role of preventative treatment, where Dr. Sahai has already said. So source control is very important, cannot be delayed, and it should be done as a minimal intervening procedure. We should not take it too long also.
Yeah. Thank you, Dr. Asif. We are running out of time. I'll just put a small question to Dr. Maya. How to adopt this global sepsis bundle in a resource-crunch setting of our Indian subcontinent? Because everything is not possible in all the ICUs. So in pediatric cases, how you are going to come up with a solution for these?
Thank you, sir. Most of the Indian subcontinent has this problem of shortage of trained staffs. The infra is lacking, PICU is not well equipped, and advanced technology is not present. So whatever is the case, the non-negotiable thing which exists is the rapid and early identification of sepsis. Features which are suggestive of sepsis has to be identified, and septic shock has to be identified, which is characterized by tachycardia and reduced perfusion, because hypotension is a very late feature in children. And in doing so, the first 1 hour of sepsis bundle, to activate it, we start giving intravenous access is done within 5 minutes. We give antibiotics. Now the choice of antibiotics should be, a broad spectrum can be initiated. Later on, after 2 to 3 days, when the patient stabilizes, then we can go for the stewardship. But otherwise, we can go with broad generation cephalosporin groups. And simultaneously, we need to send the samples for blood culture and the biomarkers. And immediately, we have to assess the mean arterial pressure, which can be done by pediatricians in the places which are not well equipped. Like we can do it with the pediatric general formula of age plus 55 years, roughly it comes, and systolic diastolic blood pressure, if we get then systolic plus difference between diastolic systolic by 3, that also gives us the mean arterial blood pressure. It has to be more than 65. With that target, we start the inotropes, and we have to recognize whether it is cold shock or warm shock. If it's cold shock, we give epinephrine; warm shock, we give non-epinephrine, and the patient is stabilized. And such septic sepsis tools and guidelines have to be there. A quick checklist has to be there, which can be done by each and every staff. And once the patient stabilizes, they can be stepped up for a rapid and early referral. And the antibiotics need to be stopped when the culture is available.
Just quickly, for a message to be given, I think the screening of sepsis is very important in the wards and emergency. What was suggested in the earlier guideline was the quick SOFA, the Q-SOFA, 3 parameters. You will see that the recent guidelines have actually taken it back. They say that a better indicator or better screening tool would be your news. That's the modified early warning score. I think 2 things. One, we can apply what your question was. Try to emphasize on news and mused in the wards, emergency out of the ICU, and the ICU needs to take up the sepsis bundle. I think if you're able to do these 2 steps with training, awareness, monitoring, that would be something very successful for all of us.
We are just running out of the time. 2 quick questions from the audience, if we have any. Yes, sir. Yes, sir. Dr. Acharya, sir.
Yeah. So, Dr. Acharya, I think I'll just answer that. So, initially, we don't...
Pediatrician or intensivist?
In general. I'll just come to you, ma'am. So, yes, I'll answer to that. So, if there are no contraindications, you start away with a straight 30 ml per kg. I think that's the dictum. You can give it through a peripheral line. You need not put a central line because time is of paramount importance. Once you have done this initial loading in the sepsis bundle per hour, subsequently it can't be a blanket order. It is basically based on the fluid assessment. Be it static parameters, be it dynamic parameters, but I think CVP is outdated right now. So if you're having the cardiac output monitoring, that's also difficult. But easy is what you said, the inferior vena cava diameter distensibility index. I think that can be applied on the patient's bedside. And this is actually based optimizing it to the patient requirement. You can't have a blanket order subsequently. Initially, no contraindications, fluid given through a peripheral line. Subsequently, it has to be actually tapered as per the requirement.
Okay, last
That's
question.
why I told, sir, the role of now focus is there. In emergency, you have to rely on focus. You can focus, you can see IVC diameter, you can calculate. Now nobody takes care of urine output or CVP, nobody. If you are following a sepsis bundle, you have to use focus and then straight like this.
Yeah, I think it's a combination of all the factors. So even POCUS, that comes for the screening for the hemodynamics, but every single parameter. That's the purpose of a bundle. We just can't get off with one parameter. Yeah, ma'am.
Yeah, but even if focus is not available, if an visible abscess is seen, that needs to be drained, or an infected line has to be removed. And fluid has to be given from 30 ml per kg up to 60 to 90 is now the recommendation. Dr. Praveen Kilani, intensivist, he recommends up to 90 ml per kg. Yeah, pediatric population, I'm talking about pediatrics. No, for pediatrics.
Yeah. Thank you, ma'am. I think it was an excellent discussion.
Thank you.
And we had a very good idea about management of sepsis. All the panelists were excellent in their presentations, and then later on explaining the nonsense of sepsis. Thank you all. Thank you, sir.
Thank you, sir.
Dr. Sahai.
I request all panelists and moderator be on stage. I call Dr. Jitin Nath Sarangi, CMO in charge IRINL. Sir Sarangi, sir, please come on the stage to felicitate our panelists and moderator. Dr. Santosh Kumar Chobe, please come forward. Followed by dual role of Dr. Anurag Krishnan Sai, please come forward. Now Dr. Maya Bose. And none other than Dr. Asif Ahmad. And I should not forget our scientific in charge, Dr. Ajit Karmakar. He has managed session very wonderfully. Dr. Ajit Karmakar. Thank you all of you for this interactive session. Now I call our very eminent guest speaker, Dr. Kunal Sarkar, on the stage to speak about recent development in cardiac surgery. Sir. And to chair the session, I call Dr. Vinita Singh, GM Tata Steel, and Dr. Jayant Kumar Acharya, CMO in charge, Rourkela Steel Plant. Sir, please come on the stage. Dr. Vinita Singh and Dr. Jayant Kumar Acharya, sir. Dr. Kunal Sarkar is a very senior cardiac surgeon, and his current position is senior consultant in cardiac surgery at Manipal Hospital, Kolkata. He is specialized in adult cardiac surgery, coronary artery bypass surgery, valve repair and replacement, complex high-risk heart surgeries, and minimal invasive cardiac surgery. He has more than 25 years experience in cardiac surgery and performed several successful cardiac surgeries, operations, extensive expertise in advanced and high-risk surgical cases. He has done his MBBS in University of Kolkata and MS in general surgery, then followed by MCH in cardiothoracic surgery. He has advanced cardiac surgery training in United Kingdom. He has many achievements and recognition nationally and internationally, frequent speaker in medical conferences and public health forum, and he featured in media for contributing cardiac care. I call Dr. Kunal Sarkar for his lucid presentation. Sir, please come on the desk.
We're just waiting with bated breath as the presentation loads. Is it loading? It's loading. Got a pointer? Thank you. From a very personal note of gratitude to all our friends that you all have given us an opportunity to be with you for this wonderful, very well organized meeting. It will be a big favor if you can shut the door for a while, because I don't think it's adding a lot to the oxygen saturation that is needed. Friends, cardiac surgery is in some sense a wide topic. And in some other senses, cardiac surgery, please remember, we are the youngest kid on the block. If you compare cardiac surgery with any other field of surgery, whether it is gynecological, which was somewhere, already implemented in the times of Julius Caesar, from gastroenterological surgery, which already reached its zenith in the times of Billroth in Vienna, we are the newest and the oldest kid on the block. You did not have the first meaningful cardiac surgery till well into the 1960s. So it is not only rapid, it used to be and perhaps still is in one of the commonest surgeries presented worldwide, done worldwide. There was a time in the United States when you had more bypasses than appendectomies being done. The profile has changed, but today what we will discuss with you is an update in what is happening to something which is very familiar to all of you, which is regarding coronary bypass. So we focus on coronary bypass today. You see, cardiac surgery, or for that matter, anything to do with cardiovascular medicine, starts with an admission. And that admission is that the mere terminology, all the time we talk about arteries, 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 but we have to do so from a position of guilt. We have to realize that the mere word arteries is a misnomer. It is a great mistake, historical mistake, because whoever termed the word arteries, it does not actually mean that blood vessels that take blood. The word arteries actually means tubes that convey air, oxygen. And that is why arteries were called arteries air and turon, a mistake that was made somewhere in the 6th, 7th century BC, and we are still living on with the same mistake. There are some people, to whom this whole evolving area of surgery, we all did, or we are supposed to take the Hippocratic oath when we qualify in medicine. And Hippocrates, in his 65 pages of Hippocrates' treatise, as they called it, said one thing repeatedly, that you will never operate on the heart. The Greeks were extremely scared of operating or cutting open anything that contained blood. So we, the people who today practice cardiac surgery, do so going against the edicts of Hippocrates, etc. A succession of people, many, many more, starting from 1917, the last surgeon to have been given the Nobel Prize, Alexis Carrel, is probably a founding father of vascular surgery, born of very poor family, very poor parents. Alexis Carrel's mother used to stitch torn clothes for a living. And Alexis Carrel saw his mother stitching torn clothes. And that stitching technique, that technique of continuous suturing, he applied from his mother's torn clothes to the blood vessels. And that's how vascular surgery, because you had no continuous stitching before that. That is how the fundamentals of cardiac surgery established. History is very funny. We got to know a little bit here and there. People got to know that if the arteries get blocked, you get lack of blood supply. If it happens in the heart, you get angina. But we had no way of detecting. How on earth can you go and detect a blockage inside the heart? In other words, to do an angiogram. And the coronary angiogram again happened by mistake, because this gentleman, Mason Soanes in Cleveland Clinic used to smoke all the time. Every 20 minutes, 15 minutes, he used to have a cigarette. So he was doing a different vascular catheterization. He went out for a cigarette. He left the catheter to his trainee, and the trainee by mistake floated the catheter into the right coronary artery, and by an and the patient had ventricular fibrillation, had a cardiac arrest, had to be massaged on the table, somehow survived, and that is for the first time. It is because Mason Soane was an incorrigible smoker that we realized that coronary angiography was actually possible. And then, as people were struggling, the first coronary angiography was done in 1958. For almost 10 years after that, now we know that, arteries get blocked, people get chest pain, you get myocardial infarction, but we didn't know what to do about it. So as everybody was struggling and trying to find out how on earth do you go and correct this condition, this surgical trainee, he had not got his degrees yet. You have famous Argentinian footballers. René Favaloro was a young Argentinian trainee who was training in Cleveland Clinic. He saw all these people trying out different things, and this fellow, humble trainee, suggested the technique of saphenous vein graft to the coronary arteries, and that really led to an explosion in the field of surgery. The first bypass was done in 1967. 1967, for those of you who care about the history of medicine, is a great year in the history of surgery. In May 1967, you have the first coronary bypass. In December 1967, you have the first heart transplant. And somewhere in the middle, in October 1967, you have the first liver transplant, the first successful liver transplant happening at Johns Hopkins. So 1967 was a very busy year for surgeons. Thereafter, let us remember a few surgical principles. The entire difference between interventional procedures like an angioplasty and a coronary bypass is basically one. In angioplasty, which is good and effective, they are actually dealing with the diseased portion of the arteries. And in coronary bypass, most of the time, we are dealing with the healthy part of the arteries. We do not intervene directly where all the grunge, the atherosclerosis, and the plaques are. So some of the difference in long-term outcome that we will see is possibly due to this one principle, that we are not getting on headlong in the severely diseased part of the arteries itself. When you go through the annals of surgery and try to find out one particular publication which made a tremendous difference to the outcomes and the way surgery is practiced later on, it is this particular paper which comes out from Dr. Floyd Loop, again at the Cleveland Clinic in 1986. So for coronary surgery, which had just come onto its own in the early 1970s, within the first 16 years, they come out with the surgery of putting the left internal mammary graft on the left anterior descending. And why was it so important? Because this was one surgery that did not talk about graft patency. It did not talk about the trivialities of surgical technique. It spoke about one thing. In a matter of a few years, there was a dramatic difference in the 10-year survival of patients. So this is perhaps an epical paper in medicine where this is one technique, and you can think of anything to do with medicine which makes a substantial difference to the 10-year survival of human beings. We went on, left internal mammary, all of you know, was a very good thing. left internal mammary with maybe a combination of vein grafts was considered to be the standard surgery. And then our colleagues started thinking about, what about if we extend the concept? What about we start using the left internal mammary along with the right internal mammary, along with the radial artery? Will it further improve results? Will it further improve outcome? Was $1 million question. And there were many, many mostly retrospective studies like this which did point out that if you extended the usage of arterial grafts, your outcome further improved. Now, there are two things that we study for ourselves. Our central milestone, our central focus, number one, is you are doing a vascular correction. How well are the grafts patent? So graft patency, the patency of the graft, you've joined A to B, they've got to flow, they've got to work, they've got to function. So graft patency is paramount. And thereafter, we have operated on a 50-year-old. So sending the patient home at 7 days is not the end point. The end point is following up the patient for the next 10, 15, 20 years. So these are the two parameters that crop up repeatedly in our work. So when we look at the graft patency of the extended arterial grafts, they were superior to that of the vein grafts. Even the vein graft patency improved. Why did the vein graft patency improve? Not because we were stitching better. The vein graft patency improved because of the adjuvant medical treatment. With the advent of statins, with the advent of dual antiplatelet therapy, vein graft patency that is seen in this era compared to the last era is largely different. So when you talk about, there is a whole lot of clamor, there is a whole lot of skirmish, people trying to say, this is for PCI, this is for CABG, this is this, this is that. Do not complicate things. Keep one central idea in mind, and that is, for limited disease, for early disease, for non-diabetics, heart has 3 coronary arteries. For things like single vessel disease, double vessel disease, limited coronary disease, maybe more so in the non-diabetic population, percutaneous intervention, in simple terms, angioplasty, will be the treatment of choice. And as of today, coronary surgery is reserved for the heavy lifting. We are the heavy lifters. We are heavy lifting in 3 vessel disease, in calcified coronaries, in 100% occlusions. So there is a demarcation of territories, and that is well supported by the guidelines. I did not want to bother you. There are very well laid out guidelines that what treatment is effective in what condition. So world over you see that depending upon the society, depending upon the country, their biases, there is a ratio. In India currently, there are about 250,000 coronary surgeries done every year. And in India today, we perform about 700,000 angioplasties. So the ratio that is prevailing in India today is somewhere at 3:1. So if you consider the total number of people who undergo bypass plus angioplasty, it's almost like the population of a tier 1, tier 2 city. So every year we are adding a city to India when you do coronary procedures to about 100,000, to about a million people. There are certain, I do not want to overburden you, there are always grafts, survival, patencies, etc. But there was a period of time when there was tremendous debate that how does angioplasty do, how does bypass do. So what we just said, the summary, that for the less complex disease, angioplasty fares equally well. But when we consider complicated disease, diabetics, these are the kind of studies. There was a trial called the Syntax trial, which is the kind of the North Star of academic medicine in cardiology and cardiac surgery today. And basically what it showed, that the longer you followed up the patient for complicated coronary disease in diabetics, results of surgery were better. Not only were results of surgery better, but what is important is today you're operating on a 50-year-old, a 55-year-old. You are not looking at a 1-year survival. You are not looking at a 2-year survival. You are looking at a long-term outcome. Even in India, your median life expectancy today is 71, 72 years. So it is not enough to operate on a 50-year-old and send them home and say that consider yourself lucky if you've survived for 3 years. That is poor medicine. So once again, in complex coronary disease, the longer you follow up the patient, the difference between bypass and angioplasty in complicated diseases, it becomes more and more pronounced. In surgery, we are always complaining with our cardiology friends. We are very good friends with them. We don't quarrel too much. Almost, there is some message coming over here. What is this? Can I have somebody over here, please, quickly? Some back-end person. What is this coming out? Some one drive, two drive. What is this? Can you just switch it off? Take it. So I'll just give you some of the nasty stuff that we have to deal with. How big is a coronary artery? A coronary artery at its biggest is about 2 millimeters in diameter. I don't have much left on my head. For those of you whose scalp is a little bit more generously covered than mine, it is about 5 of your hairs put together. So that is the arteries you are stitching. And when some of these arteries become completely blocked and choked up with calcific atherosclerotic plaques, you see, we are called upon to tease out these plaques from the coronary arteries. This is the kind of stuff that comes out. So many of you may have seen peripheral endarterectomies. So coronary endarterectomies are still quite a prevalent procedures. Very often we do triple vessel disease of which 2 vessels are completely knocked out by solid atherosclerotic plaques. So complex plaque division, plaques are like wood. You can't really stitch an artery on a vein to a stone. So you have to clear the coronaries whenever required. And we do so. Nowadays, it is like repairing an engine when the heart is working. So this is a beating heart surgery where so this is a complete left anterior descending artery which has been cut open from the base to the apex. The whole artery is laid open. The entire plaque is taken out, and only then can we restore the circulation. There are certain difficult areas, very difficult areas. The starting point of the cardiac circulation, the left main artery, 15% of all coronary disease happens in the left main artery, and the left main artery lesions have to be detected early. Because other than that, if you've had a myocardial infarction from a left main artery, God save you, because in matter of minutes, 3/4 of your myocardium will be knocked out. So in left main coronary arteries, also looking at their survival, bypass remains a better option. And where the difference is extremely remarkable, that is in low ejection fraction. About 80% of the people come for intervention by the time they have already had 1 or 2 infarcts. So by the time if you've had 2 infarcts, you will be very lucky if your ejection fraction is anywhere between 35 to 40% as compared to a normal of around 60-65%. So in low ejection fraction, say in a diabetic with multiple coronary artery disease, this is one of the difficult, it is challenging, but it is one of the areas where the long-term results of bypass are remarkable. And similarly in diabetics. If you follow up diabetics, in India, you need a few things to prove your identity, either an Indian passport, an Aadhaar card, or your blood sugar levels. If you are a diabetic, nobody questions your Indian identity today. And given this prevalence of diabetes, this is something which is important in our area of work, because the longer you follow a diabetic, the more intent you have to be on the long-term outcome. Now, we have to be aware of the fact where are some of the weaknesses, where are some of the pitfalls. We are in the business of making the blood supply normal, or in other words, complete revascularization. So if you get into an operation or you get into an angioplasty where somebody has a triple vessel disease, and you go out of it correcting one artery or two arteries, and you think somehow the person has gone out of the theater, so all is well, that is extremely wrong. The medium-term to long-term outcomes of incomplete revascularization are poor, no matter who tells you what. So whether we are doing it with a bypass or an angioplasty, complete revascularization is absolute priority. There are some other additional problems which can only be corrected with surgical intervention. Post-infarct, the mitral valve will weaken, the ventricle will dilate, and in that setting, along with coronary artery disease, we are going to see ischemic mitral regurgitation. If the ischemic mitral regurgitation is severe, you cannot just put 2 grafts or 3 grafts and send the patient home, because the guy will go home and start and continue to be breathless. So in that case, if the mitral regurgitation is severe, then it is very important to repair the mitral regurgitation and then do the bypasses as well. Now, as time has gone on, we, the surgeons in India, had our own share of innovation. And one of India's gift to bypass surgery over the last 20 years has been the concept of beating heart or off-pump surgery. Till about 1990s, routinely every surgery used to be done on stopped heart, heart-lung machine, and the whole paraphernalia. Around 70% of coronary bypass today is done on off-pump beating heart. What is the advantage? Less physiological stress for the patient, earlier recovery, less transfusion, less ventilation. So it has its own advantages. There was a lot of controversy that whether when you off pump is like a bit of an acrobatic act, that you are trying to stitch these little coronaries with the heart beating in front of you all the time, or is the grafting outcome, is the grafting result as better? So we in India, 5 surgeons got together and we did what is considered to be the first randomized controlled trial of coronary surgery from India. For the first time ever, we studied more than 500 patients with post-operative angiograms in off-pump surgery, and to cut a long story short, the outcomes were comparable. So even with off-pump work, you compare across the 3 territories, the outcome was good. We have recently completed our second RCT, which is how does a diabetic do with a second arterial graft. We have just collated the data. The abstract will be presented in the American meeting this year. So it is difficult to do serious academic work from India, but we are at it, we are persistent. So the PREDICT trial will be the second academic work from India going on. At the end of it all, you must have heard, you are familiar with the term of minimally invasive cardiac surgery. Now, why was minimally invasive important? Because cardiologists in a friendly kind of way was always poking us for our sternotomy approach. You had a big cut down the middle. Years ago, a sternotomy used to be a status symbol. You went to a party, you told somebody, I've had a bypass, your social status increased. But then the cardiologist used to say, we are doing it with a small hole in the wrist. So the cardiac surgeons got together and devised certain very ingenious techniques. Today, there are minimally invasive surgeries done with a smaller left side of the chest, a small anterior thoracotomy, as opposed to a full-blown mid-sternotomy. But mind you, as I tell my patient, measure your life in years, not in inches. So when you calculate your age is still measured in years and not inches. So if it is a complex disease involving right, left, both aspects, it is still today a sternotomy. Supposing you have a double vessel disease both on the left side, it's basically a concept of geography. then minimally invasive surgery is quite effective. Minimally invasive surgery, the approach is very different. I won't bother you with the surgical details. As opposed to the middle of the chest, you have these smart little retractors, and with these little retractors, we harvest the mammary, we do the anastomosis all at the same time. But it is effective. And once again, it is not enough to sell you a gimmick. You know, we are doing a small cut, doing bypasses. Once again, you have to go back, do angiographies, study the grafts and prove that the grafts are working. But remember, minimally invasive surgery is done in selective cases. It is not an all-comers operation like your conventional bypass, but in those selective cases, graft performance is good. The newest innovation in the block, which we have put our hat on the ring, we've done about 15 of those so far, is this new concept of robotic surgery. We have a Da Vinci robot with us. The Da Vinci robot, you know, there are 15,000 Da Vinci robots all over the world, and robotic surgery is very popular mostly in pelvis, in gynecology. Those are the areas where robotic surgery dominate. But we are getting into the act right now. What do? We use the robot mainly to harvest the mammaries. This is the robotic ports going in like any other robotic work. So once the ports have gone in, we are using the ports to harvest the mammary out, because in that case you don't even need that, the cut in the chest can be even smaller. So we are harvesting the mammaries through the port, and after we have harvested, the anastomosis is still done hand-sewn. There is a lot of development going on for robotic connectors. Connectors, which is you will put it's like two staples. You'll put them through the two arteries, fire the staple, the arteries will connect. Mind you, looks good on the drawing board, still not widely available. There are anastomotic connectors, but for all practical purposes, for most robotic work, the anastomosis is still hand-sewn. Robotic graft patency, we have to be careful. In a very selected cohort of patients is pretty good. Now, the basic concept that I want to leave you with today, that it is not a matter of sibling rivalry between an angioplasty and a CABG, but coronary bypass has held its ground. And why has it held its ground? Because it is capable of tackling the severe problems, the diabetic, the calcified disease associated with valvular lesions, poor ejection fraction, and at the end of it all, it is giving something that all of us want, and that is better survival. And one example is one of the recent publications from the Journal of Annals of Thoracic Surgery. Now people are coming up with 40-year data. Next month we are going to have 50-year data on the patency of arterial grafts. There are not many surgeries on the face of the planet today who are publishing 40-year and 50-year data for an operation that was only invented in 1967. So it's still the long-term outcome, the survival, which remains the strength of coronary bypass. In Eastern India, coronary bypass or cardiac surgery has grown in great leaps. Today, the centers around India does about 250,000. We in Eastern India today are little short of 30,000 procedures per year. And we in Manipal hospitals, I look after the Manipal cluster in Dhakuria and EM bypass. We do about 2,000 a year, and perhaps we are the largest cardiac unit in Eastern India right now. I don't think there are any other units whose either volume or spectrum of cases. We do everything, starting from a 2-day-old kid to a heart transplant. So from neonatal to heart transplant, we have our colleagues who are performing the entire range of cardiac work. How much do we know? I think in Eastern India, we are only doing half of what we are supposed to do right now. We have our concerns. We'll discuss this later. There is a lot of inappropriate referrals for PCI. Once again, this is not selfishness, but when we make inappropriate referrals for angioplasty, remember at the end of the day you have perhaps compromised on the patient's survival, not in terms of 7 days, but in terms of the next 10, 15 years to come. And there is a calculation which says that if you select your cases well, and 10% more deserving patients come to the bypass category, you would have saved 3,600 lives per year and about 1,000 crores in revenue. That is what will be the impact. Both as surgeons, as cardiologists, as non-interventional cardiologists, be aware of the fact that in India we are still severely underperforming. If you compare ourselves with the benchmarks, we are a kind of mid-low income country right now. Compared to our current benchmarks, it looks very good. We are doing 250,000 coronary bypasses, about 300,000 heart surgeries per year, but we have to remember that is gross underperformance. I have just written a paper that will be published in the next couple of months just to show that India currently is only doing half of what it's supposed to do. All these things about, Viksit Bharat and everything is emotional propaganda is fine. But if you put your emotion to numbers, you will realize where you are in reality. And as we become a kind of middle income country by next year, our performance gap will be even more. So I think we are only at 50% of our capacity now. We have to diagnose more, we have to detect more, otherwise we are not doing justice to this disease spectrum. And let us remember that with an insured population, I am not talking about people who cannot afford, with an insured population which is 3 times larger than the population of United States, we are not even performing half their numbers. This is something that doctors in India should be severely concerned about. The insured population of India is 3 times the population of United States. So our goal should be that we detect more, we allocate therapy smarter, we treat better, we save more lives, we conserve resources, and at the end of the day, we have to do our specialty some respect. Thank you ever so much. If you have any questions, I'll be happy to answer.
Sir, myself and Dr. Vibhuti Karuna from Bokaro. Sir, just that I think 15, 20, even more of our eligible CABG patients are undergoing coronary intervention. Even then, they are diabetic, they are multivessel disease, they are complex lesions. And we are putting the responsibility on the patient as because they are not willing for surgery. So how it can be tackled up? Because in coronary angiogram, we are mentioning that the choice of representation.
There are two parts to it. We should not be lenient to ourselves. We have to be very cruel to ourselves. At the end of the day, you see, we human beings, Homo sapiens, are essentially selfish people. So there is a little bit of personal and professional selfishness which we cannot ignore. But look at the other side. The other side is India has 1,700 cath labs throughout the country, 1,700 cath labs. We hardly have 350 active cardiac surgical centers. So I'm a little bit aware of the fact at one time I used to look after the unit we had in Ranchi and all that. So especially in the kind of tier 2 cities, tier 1 cities, in the industrial townships, I think better penetration, and in today's technology, much more discussion needs to happen. Okay. And then again, in our fragmented system of medicine, you see, you and I go home thinking, that is very uncivilized, thinking that the patient is yours. If a doctor goes back home thinking, this is my patient, that is where medicine has been defeated. And it's not your wife, it's your patient. And if you look at your patient as your patient, then you will understand that the patient has to have a form of treatment which is rational, which is justified. Today, the commercial transaction supersedes medical logic, end of story. And we have infrastructural deficiencies, which I think will get better, which I think will improve, but we have to point it out. We had a national association, I look after the national database, and they were jumping up and down last year. This year we will do as many coronary bypasses in India. We've almost, for coronary bypasses, we are almost near United States. They are at around 320,000. We are around, maybe this year will be 270, 280. But as I told you, the entire population of United States is 26 crores. The number of insured people in India is about 72 crores.
So the responsibility is
you and I
taken
cannot,
by us.
you and I cannot go home doing that moral science, Gana Bajana, India, poor people can't afford expensive medicine. What poor people, man? Number of insured people are about 72 crores in your country. What are we doing about it? So we have to realize that is where our shortcomings are. But I think more communications. If you are in a tier 1, tier 2 city, if you are in an industrial city hospital, establish more. We are more interested in referrals. And pardon me my saying so, and the benefits that come out here with. But today, is it very difficult to talk to a person, get him on a Zoom call, get him on a WhatsApp call, film your angio, send it to anybody you think fit, have a 10-minute conversation. We have to do that. Because unless we do that, I cannot see 1,000 cardiac surgery. USA has 1,200 cardiac surgery centers for their population. Forget about USA. India-US trade deal will not equalize medical infrastructure, sadly. So, but we at our present position, we have to communicate more, make good use of technology, we can speak to ourselves, develop heart teams on the virtual network. Why can't we do that? It's our failing.
Thank you, sir.
Yes, sir.
Thank you,
sir. One question. Dr.
Running out of time.
Yes, ma'am.
One question. Dr. Madhavi from RINL Visakhapatnam, sir. Sir, in your experience, post-graft blockage, is there any?
It's well calculated, ma'am. You see, at 1 year, if you follow your patients for the first year, you are going to see about 1 to 2%, right? If you follow them for about 5 years, your graft patency rates will drop by about 5 to 7%. If you follow them up for 10 years, your graft patency rates would drop by about 20%. But what is critical, you see, as compared to, again, I don't want to get into this bypass angioplasty repeatedly, but in bypass what happens is, say you have an internal mammary to LAD. The 20-year patency rate of internal mammary to LAD is 92%.
Okay.
92%. There are many reasons for that. So, yes, there are drop-offs, but at the end of the day, if you've got like 60% of your myocardium well perfused, that is a big advantage for the patient. And things which are making a difference, we surgeons were also stupid. We would think, I've done a fantastic operation, I will not bother about the dual antiplatelets, I will not bother about the LDL targets, I will not bother about the HbA1c targets. No, that is wrong. If we are also stubborn like that, and your HbA1c is 9.5, and I tell you that you are going to have same graft patency at 5 years, you won't. You won't.
Thank you, sir. Thank you for enlightening us on such a newer advances, and you have really given us an input about the benefits, pros and cons of both the procedures. So with this, we come to the end of this session, ma'am.
And thank you, sir, for this excellent talk, sir. Now I request Dr. Vinita Singh and Dr. Jayant Kumar Acharya, sir, to felicitate our speaker, Dr. Kunal Sarkar. Thank you, Acharya sir. Thank you, ma'am. I request Dr. Rajanjan Kumar sir, CMO in charge, Durgapur and Banpur, to come on stage to felicitate our chairperson, Dr. Vinita Singh and Dr. Jayant Kumar Acharya. Thank you, sir. Thank you very much, sir. Thank you, sir. Thank you, sir. Thank you. Thank you very much, sir. Thank you. Now we have come to very interesting session, that is TQM paper session. And for this, I call on the stage Dr. B.B. Karunamai, ED Medical and Bokaro Steel Plant, and Dr. Vinita Singh, GM Tata Steel, on stage to chair the session. Dr. Karunamai and Dr. Vinita Singh. Be sure that all speakers should be there in hall. I will call one by one, or they can come backstage to save the time.
Yeah, I think it's a good idea. Please maintain the sequence and be there so that we can start paper and do it one after another. So the first speaker is there?
Yeah. First speaker is Dr. Bulu Sharma from Durgapur Steel Plant.
Yeah. And if the second speaker could be, ready for the next one. And
Good afternoon, ladies and gentlemen, and dignitaries on the dais. Today I am here to speak on improving turnaround time in emergency samples, especially electrolytes, through DMAC. Quality means when we are able to satisfy the needs and expectations of our customer, our patients, and our clinician. In lab services, it is not only the accuracy or reliability of test result that satisfy the patient or the clinician, but the quick availability of lab result is actually crucial in the management of critically ill patients. That is why it is considered urgent and important in the priority quadrant. There are various definitions of TAT are there, but for our study setting, we have taken lab TAT, which is the time between the sample is received in the lab till the report is ready to be informed. We defined our problem statement as the increased turnaround time in emergency samples. Those which had TAT of more than 2 hours were considered outliers. Those outliers were on an average 71%. Our goal was to bring it down to less than 10% and also to minimize TAT to maximum extent in emergency samples, especially for electrolytes. Our constraints were indoor sample collection services as well as sample transportation services, which were not in our control. And exclusions were routine and outsourced sample. A schedule was laid for the implementation of DMAC project. Time was recorded at 5 stations for calculation of TAT. This is the process map of our lab, which shows that how the sample is received, analyzed, and further report is ready to be informed to the clinician. It takes a total TAT of approximately 1 hour 30 minutes. whereas lab TAT is 30 to 40 minutes. Here we can see that the sample clotting time is taking maximum time of approximately 30 minutes. Brainstorming was done to find out the root cause analysis, and the causative factors were in pre-analytical, analytical and post-analytical phases. In fishbone diagram, the causes were found to be under 4 main headings of instrument, specimen, processes and personnel. Further, in Pareto analysis, the vital few causes were found to be increased clotting time of the sample as well as abnormal sample due to hemolysis and insufficiency. Again, brainstorming was done for the corrective measures, and very innovative step was adopted in our lab, that is addition of 1 drop 0.05 ml of heparin solution in an empty sterile vial for the analysis of the emergency sample. This step has actually skipped the sample clotting time of 30 minutes completely. These are the various recommendations which shows that the amount of heparin to be added for analysis. In fact, International Federation of Clinical Chemistry also recommend the heparin amount should not be more than 5%. Our Bible of Biochemistry, Teach's Biochemistry, also recommends that for electrolyte estimation, especially for potassium, blood should be collected in heparin vials. ADA and WHO also recommends that plasma glucose should be taken for diabetes diagnostic criteria. In our lab itself, we have done a pilot project of 11 samples to compare the serum and plasma values where no such variation is found. Most importantly, between the POCT instrument, ABG and lab analyzer, autoanalyzer, various studies has recommended that for confirmation, autoanalyzer values should be taken because no such correlation between both are found. Now, what we have achieved after adding 1 drop of heparin in 3 phases of machine running, we are able to report electrolytes within 10 minutes and all the blood biochemistry profile within 15 minutes. These all values were increased by 30 to 45 minutes before addition of heparin. This is very important because in most of the renowned institutes, they are not able to report electrolytes before 35 to 40 minutes. In this line graph also we can see that the outliers, which were previously 71%, has come down to less than 10%. That is, we have achieved our target with a significant p-value. An improvement strategy, in the biochemistry department, training of staff for adding heparin for making of the vials and physical check of the sample is given. Analyzer training of the staff for stat sample run on the autoanalyzer is also given, which is a specific step. In the clinical department, like in ICU and medical wards, sisters are taught for making of the heparin vials. These are some of the training pictures where they are taught that how 1 drop of heparin has to be added exactly at the center of the tube. As control and future measures, monthly TAT review in lab quality meeting is continued. Pneumatic tube system to be introduced with LIMS, which would save the cost on transportation staff. To summarize, a reduced turnaround time in emergency samples is utmost important, as we have heard in the panel discussion. So, especially for electrolytes, as abnormal potassium concentration, they are reversible cause of cardiac arrest. And by calculating the anion gap, we can diagnose many diseases. By adding 1 drop of heparin, actually we are reducing the TAT to less than 10 minutes for electrolytes. The outliers have come down to 10% from an average of 71%. This has actually led to increased efficiency of the clinician, decreased hospital stay, improved patient outcome and increased hospital revenue. As a future project, AI can be incorporated for calculation of TAT, and this would definitely help in real-time capturing with proactive intervention, would improve patient satisfaction. With this, I rest my presentation. Thank you.
So nice presentation. We can have 2 questions.
Yeah, ma'am, good presentation.
Thank you, sir.
Just want to know, the study has been good, but addition of this heparin, what is the effect on the serum electrolyte? Because potassium is very important, you have rightly said, not just for the gap, but if we get a wrong value based on the test reports, it will not be actually right for the patient. And it's supposed to bring down the levels of potassium and sodium.
Due to dilutional effect, you are telling,
yes,
sir?
Yes,
sir. 1 drop of heparin, at least it is 0.05 ml, sir. If you are taking 2 ml of blood, 5% is recommended by IFCC that it should be less than 5%. The heparin amount should not be more than 5%. 2 ml of 5% is 0.1 ml, sir, and we are giving 0.5 ml.
So as a pilot, you could have also added,
Yes, sir.
basically by addition in the same sample,
Yes, sir.
with and without heparin, what was the difference? Maybe
Sir, we have-
few
we have
tests. You've
checked
done
it,
it?
sir. Yes,
okay,
sir.
I've
Yes,
missed out
yes.
maybe. So how was it?
So it was good. There is no such difference.
Have
sir.
you
Not-
put up in your paper? What
Sir,
was that
serum and
called?
plasma correlation is given. The particular
No,
param-
addition of heparin I'm asking, because this is the relevant factor.
Yes,
in your
yes, sir.
study.
Sir,
Yeah.
you can see the values here, sir.
No worry, no worry. You can just tell us what's the result for that. Was it same? Was it different?
Sir,
or you
for
have taken as a
potassium,
correction value?
yes, sir. Sir, in literature, it is there that 0.2 to 0.7 millimole difference.
No, no, your study, not
Yes,
literature.
Sir. So it is not more than 0.2 to 0.3 for potassium.
Yeah, ma'am. Good afternoon.
Yes, good afternoon.
So, can you go back to your that heparin slide which you
Yes,
showed?
sir.
Yeah,
Yes, sir.
Thank you.
This one, sir?
Okay, what was the type of heparin used to
Sir, it is liquid heparin, and liquid heparin is available as sodium heparin only.
as sodium heparin?
Yes, sir, sodium heparin.
So, but literature says that you cannot use sodium heparin or ammonium heparin.
So that's what the sir said, no? The amount of heparin, that is important, sir. 1 drop of heparin is actually not affecting the values much. We have done it, sir. We have compared it.
Yeah, thank you.
Thank you, sir.
Can we have the next presentation ready? Dr. Prashant, please. Sharma, yeah, Dr. Prashant. Dr. Samik is the next speaker. If he,
Good afternoon, respected chairpersons, ladies and gentlemen. Non-operating room anesthesia, or NORA, is the administration of anesthesia outside the operation theatre, commonly in endoscopy, CT MRI, or the cardiac catheterization lab. Endoscopy comprises the majority of these cases, and the benefits of peri-procedural sedation are numerous, so much so that now the percentage of patients undergoing colonoscopy under sedation is a newly introduced KPI for any hospital in the 6th edition of NABH. So to analyze and further improve the utilization of NORA at our facility, we planned this project in the first quarter of financial year 25, implemented this as soon as from the second quarter of the same financial year, and currently we are in the sustenance phase. We followed the PDCA cycle for our project, where in the planning phase, when we mapped the pre-existing process, we found it to be mostly manual and involving a long communication chain where a number of phone calls and WhatsApp messages were required to either raise a PAC request or to schedule a case. And it was only after this cumbersome process that the patient was able to undergo the procedure under anesthesia. To further understand the various factors contributing to inadequate NORA utilization, we used a quality tool such as the fishbone diagram depicted here, where the key factors were a lack of understanding among stakeholders, manual or informal communication with no standardized workflow, no real-time measurement tools, and the absence of a dedicated digital interface for NORA. Another quality tool we used was the YY analysis, where the root cause we found was a lack of understanding of relevance and inadequate understanding of process capability. We identified the problem as the absence of a standardized, fast, process-oriented, and digital scheduling system, which restricted NORA utilization despite available capacity and patient demand. There's a famous saying in quality, what you cannot measure, you cannot improve. So we defined the KPIs. A primary KPI was the percentage utilization of potential available time for endoscopy under GA, which in the pre-implementation phase was only 30%, and a secondary KPI was the percentage of total endoscopies under GA, which was only 7 to 8%. Our project was not merely based on perception, but on standard statistical tools. So we defined our objective as to increase the percentage usage of potential available time for endoscopy under GA by 50%, which translated to 28 cases or an additional 10 cases from the baseline. In the do phase, we adopted the Japanese work methodology of the 5S implementation, where a cross-functional group was formed to analyze the workflow and form an HMS module for NORA. Through segregated days for endoscopy and MRI, comprehensive training, parallel system operation for some time, the team finally achieved full digital adoption. To further streamline the process, we segregated the working days of the week among endoscopy and CT MRI under GA. As you can see, this is the new requesting and scheduling process on a hospital information management system with the newly formed module for NORA. The post-rollout workflow was mostly digital and involved a very short communication chain where the PSC request as well as the scheduling could easily be done on the hospital information management system, which provided better visibility and transparency to all our stakeholders. In the check phase, when we did the quarterly analysis, you can see that the average monthly endoscopies under GA showed a consistent improvement post-implementation of this project, and currently with around 50 cases per month in the sustenance phase, we have superseded a target of 28 cases per month. This graph speaks for itself, where a primary KPI, that is the percentage utilization of endoscopy cases under GA, nearly tripled. That is, it improved from 30% to an impressive 87%, with a 190% increase against the baseline. And with increasing number of patients opting for endoscopies under GA, our secondary KPI also improved from 8.45 to above 20%, with a 143% increase against the baseline. So as we all know, utilization of an OT more than 70% can be termed as optimal. So with an 87% utilization, we not only achieved our target, but we also ensured optimal utilization of the endoscopy suite as well. However, we did not rest on our laurels, and in the act phase, when we realized that the number of patients needing GA was much more in endoscopy compared to MRI, we allotted an additional day of endoscopy under GA to accommodate these patients. Some of the sustenance initiatives we undertook, we have now incorporated the protocol for sedation in operation theatre as well as NORA in our departmental SOP, and is stringently followed by all anesthesiologists in the department. We have implemented this process as standard for all NORA cases, and we are also ensuring continual management review, which is done quarterly. The intangible benefits we have gained from this project, there's a persistent optimal utilization of endoscopy under GA without compromising safety, and we are the only center in Jamshedpur to offer challenging pediatric CT MRI cases under GA, and there's perceived enhancement in patient experience as well as morale and satisfaction of hospital staff. Thank you.
A good topic. So we can have discussion in short.
Yes,
Dr. Prashant.
Yes.
Myself, Dr. R.K. Gautam from Bokaro. What do you mean by lean in terms of healthcare system?
Lean is...
And another part.
Okay.
Does your this lean digital intervention directly affects the patient safety?
Lean is eliminating the waste. The waste here was the time which was wasted in the fragmented communication channels. That's why we are using the word lean in this way. The second part of the question, sir?
Does it directly affect the patient safety? Lean digital intervention, as you mentioned.
See, TQM projects are not directed towards the clinical outcomes. We are more process oriented.
Okay.
It is targeted towards the process. So by improving the process, with the process improved, there were more PACs done on time. So if the PACs are done on time, we are scheduling the case the day before. Now we are ensuring much better safety as well.
You are optimizing the system, and that is indirectly affecting the patient safety.
Yes,
Is
sir?
it that you are optimizing the system, and that is indirectly related to the patient safety, no?
That is not related. This project entirely was to improve the process.
How the patient safety is
The
related?
process improved, the safety also will improve, because we have improved the process.
It is indirectly,
Every
na?
patient who is scheduled for that case will undergo a PAC. So once the PAC is done, the patient is optimized. So obviously, safety part is also taken care of.
That's the thing I'm asking. You are optimizing the system. That is again indirectly affecting the patient safety.
So what is your...
I think it is clear that
he
the
is
process is
not getting affected on the
not
patient safety.
affecting the
Yes.
patient safety.
But what is the timing of each procedure that you take? What is the timing of each endoscopic procedure?
That is allotted as 1 hour, ma'am. Previous
1
studies,
hour.
1
So
hour.
what is the working hours of the theatre?
Working hours of the theatre around 10 a.m. to 2 p.m.
2 p.m. So in between you need to sterilize the instruments, or you have two endoscopes working at the same time?
So that is the beauty of this process, ma'am, because the patient was scheduled a day before. The instruments were ready the morning of surgery.
No, it's okay. After doing a procedure on a patient, then the sterilization procedure also has to be there for those instruments. That takes time. You need minimum half an hour for sterilization. Then you have to take another patient. So that will take up some time. So between the 10 a.m. to 2 p.m., how are you able to increase your efficiency up to 87%?
So that efficiency, ma'am, was increased due to the process. The process improvement itself led to the improvement in the
PAC is already done one a day before in every theatre. What I'm asking is how you are able to accommodate so many patients in a day, taking care of sterilization and everything in the endoscopy room. Do you have two endoscopists or you have a single endoscope?
We have two endoscopists, ma'am.
That is the reason. Then you can do it. That is what I want.
Excuse me.
Just last question, yes.
Assigning days to a procedure, what is the effect on that patient satisfaction? Because they have a long waiting time with that.
Can you repeat the question, sir?
Assigning days for each procedures, that the waiting time will be long for the patients.
So for emergencies, we can do that anytime. It is not for emergencies. These are only for elective procedures.
No,
so
suppose,
elective procedure, if the PAC
suppose
is
some
done-
patient came on Tuesday, again you will have the CT MRI on next Monday. This patient satisfaction and the will decrease definitely.
Why will it decrease, sir? Because the
So
patient
they
will be
have to
admitted.
wait
the
for
patient-
anesthesia. They have to wait for 5 days.
No. Once the PAC is done, the case is scheduled. So the patient will be admitted a day before. So what is the urgency? There is no urgency.
So
of the
if you
procedure.
can plan hours per day, that would have been better. Rather assigning days, if you assign hours in a day. Suppose in CT MRI from 2 to 4 we will do that.
We accommodate as many cases as we can, sir, because the anesthesiologist will be available for entire day. So from 9 a.m. to 4 p.m., the anesthesiologist will be there. So if there are three MRIs also, 4 MRI also, 5 MRI also, the anesthesiologist will be there.
Okay.
Okay. Thank you. Thank you.
Next, Dr. Aismoc Ranjan Sahu.
Good afternoon, respected judges, chairpersons, and delegates. My topic for presentation is Quality Improvement Project to improve compliance to antibiotic policy in ENT infections. Now look at this diagram. What do you see? An infected neck abscess in which the patient has carelessly self-prescribed, taken advice from an unregistered medical practitioner, presents late to the hospital, lands in septicemia, and dies. Now we all have survived the COVID pandemic, and antimicrobial resistance is going to be an even bigger pandemic than COVID, which we can prevent through appropriate use of antibiotics. The WHO, the National Medical Commission, National Board of Examinations, the Ministry of Health and Family Welfare, and our Honorable Prime Minister have emphasized on the topic of antimicrobial resistance and the dangers of self-prescription. That's why I've done a TQM project on this important topic. We follow the DMAT protocol, in which in the first phase we analyze the lack of compliance, and subsequently we improve in the second phase. Analyze the compliance, the self-prescription rate, the unregistered medical practitioner rate, and the overlapping prescription rate. Now coming to the causes, at the patient level, patient often self-medicated, visited multiple doctors resulting in overlapping prescriptions, did not complete the course, shared the antibiotics. I as a doctor was less aware of the recent guidelines of antibiotic stewardship. Pharmacists who explain the patients of the directions of antibiotic use, sometimes they spend less time with the patients while dispensing, and there were some miscellaneous causes. The Pareto diagram shows that the major causes responsible were self-medication by the patient and the patient not following the instructions of the doctor. I also used a check sheet weekly to catch the defaulters of non-compliant antibiotic use. Then I attended a brainstorming educational webinar on antimicrobial resistance and antimicrobial stewardship, and a lot of options came to my mind, and the options which were highlighted in red are the ones which I was able to implement in my setup. I put up signage posters in the ENT OPD and also in the pharmacy explaining to the patient of the do's and don'ts of antibiotic use. I also celebrated AMR Awareness Week in the month of November. Those resistant cases of ER discharge, I collected oral swabs, sent to the laboratory, got an idea about the organisms and the antimicrobial sensitivity patterns, and prescribed antibiotics accordingly. I also counseled the patient not to use antibiotic ear drops by self for wax and initial stages of acute otitis media where they are not indicated. I also conducted an educational seminar on antibiotic policy, discussing with multiple specialties so that I can have an updated antibiotic policy which can improvise the compliance rate. I noted improvement in compliance and the self-prescription rate came down. The patient not following the doctor's instruction, that also improved significantly. How there are certain parameters such as unregistered medical practitioner rate and the overlapping prescription, which even though improved were not significant. I continued with my awareness sessions. This is a flowchart and the PDCI cycle demonstrating the process. Many studies done in literature. The most important, the TQM study published from Lady Hardinge Medical College has used education as a tool in which the compliance improved. Kerala, the model healthcare state, has launched Operation Amrit, which stands for Antimicrobial Resistance Intervention for Total Health, in which public consultation has been used. Even the parliamentary panel suggests that AMR awareness should be integrated into the medical curriculum so as to sensitize the doctors about antimicrobial resistance and the compliance. The Indian Medical Association has also launched the AMR Smart Hospital project. I also use education, awareness, and AMR surveillance and feedback to improvise the compliance. These are the intangible and the tangible benefits. These were the limitations of my study, and I decided that whatever limitation I have done, I will be able to overcome it in the future by conducting a multi-collaborative, long-duration, multicentric study so as to find out the local prevalence of AMR and how we can bring it down by using the One Health approach. I can conclude that patient education and CME compliance, and I was able to implement the national program. The financial cost of treatment got reduced. My take-home message is use antibiotics smartly so as to prevent antimicrobial resistance. And I would like everyone, including myself, to take the IMA-AMR pledge that we as practitioners of modern medicine will prescribe antibiotics judiciously, maintaining a balance between and preserving the antibiotics for future generation of doctors. These are my references, my acknowledgements. Thank you.
Thank you. Any questions? Yes.
Dr. Sahu, good effort, I think, you have taken in your department. But this is a known fact, this is what's the result to be actually kind of gained from any kind of antibiotic stewardship. So you talked about the DMAC project being taken, right? But we did not see the tools of the DMAC coming out very clearly. Because you knew there were two factors and there you have acted upon. And that's a straightforward way, basically. So could you just highlight it, how you've gone into the DMAC project?
So first I defined the problem statement and then I monitored certain parameters.
Yeah.
Then I analyzed the causes of what were the causes of lack of compliance.
So the measure here, the measure and analysis, I think you would have taken some more parameters. Basically, you've just taken kind of non-compliance with the patients, and other one was about your prescription. So what was the compliance earlier? Did it have any impact directly? I think that measure should have come out better. To just say that you have done this. It's a very short period, but it's just that this was to be done, this has to be done right now.
So, but this is just a starting, sir. This I hope that I will continue it because it requires a One Health approach, and the Ministry of Health along with even the veterinary doctors, so that we can break the
yeah, no doubt. It's a great initiative taken because that's very important.
And also the climatic factors also we need, and the water, sanitation, all those things.
Yeah.
So it
You
will
can
not be a
still,
simple
you can
thing
still
that-
make it more robust, but it's a good initiative to start with. That you already said. Well, thanks.
Thank you, sir.
Yeah, good afternoon. It was a well-presented paper, and just a follow-up of what Dr. Asif was saying. What is DMAC used for? Why was it not a JDI or a SIP? Why did you decide to make it a DMAC? What is a DMAC used for?
So this is one of the ways you can do the total quality management approach, define, monitor, and
Right,
guide.
but why would you use DMAC?
So because this suited me, that's what I felt. Whatever steps practically I am using it in clinic, that I can fit it in there, and also that's why I used it. I
So-
defined the problem. I monitor.
So usually DMAC is used when you can define, you know what the problem is, but you don't know how to sort of implement it. Right in the beginning of your slides, you gave the PM's address and that it is already documented that we should have antibiotic stewardship. So DMAC probably was not the...
Sir, it is documented, sir, but sir, already
thank you.
AMR dates are around 2,97,000, sir, but I practically wanted to implement it. Thank you, sir.
Resolved during the lunch hour.
So
So,
the next,
thank you.
Thank you. The next speaker is Dr. Deepak Kumar Das Mahapatra from Bhilai. Yeah.
Respected judges, chairpersons, all delegates, namaskar to everyone. Our blood center JLHRC is a licensed blood center and complied with all the criteria by CDSCO. We are a 24/7 operational blood center, and we are the only blood center in Chhattisgarh having ID NAT facility, and I think very few in India have this facility. Our blood transfusion committee did regular meetings, and we did regular audits. We thought of improving our services, so we went for NABH. Why NABH? National Accreditation Board for Hospital and Healthcare Provider is the highest standard in India for quality assurance, and it is recognized globally. Its importance lies in us that it builds patient trust on us, and we meet the quality parameters set by national standards and internationally also. We follow PDCA cycle. The study methodology we conducted for 1 year, book from the NABH accredited blood center book, data collected from the institutional record, gap analysis, audit findings, and training reports and feedbacks. These following difficulties we find out: modernization and automation of instruments, introducing small changes in requisition form, feedback forms to improve our services, monitoring of temperature chart from 8 hours to 4 hoursly, authorization of critical instrument, increasing efficiency of staff by continuous training. The challenges need to be implemented through roadmap, resource infrastructure gap, operational challenges, manpower and competency deficit. The key factors are commitment from the leadership and all the staffs involved in the process, traceable enable lab certificate, meeting quality parameters set by NABH, and mandated turnaround time. We apply 5S methodology. We changes our traditional couches in camps to portable blood donor couches. We ensure that our blood center is neat and clean without any flies. We not only installed IUI station, but also donor information leaflet is being displayed everywhere in the blood center and outside the blood center. From manual to automation, we are heading. We ensure that our blood component goes through proper temperature sealed boxes, and from manual record keeping to automation. Our daily updated stock is being updated in e-Raktakosh portal of state government, and same is being displayed in the blood center. This flowchart shows from the point of entry of the donor to the counseling, to the medical assessment, to the phlebotomy, and to the post-donation care. Our requisition consent form is designed as per the newer guideline of NABH, considering routine, emergency, and immediate protocol. Blood transfusion protocol is clearly defined, and every staff in the ward is being aware of it. feedback form is taken from not only from the donor but from the clinician and from the camp organizer. Calibration of instrument is done from NABL certified lab, and again it is certified from the Government of India. Biomedical waste is taken care of as per guideline. We ensure that job responsibility of each and every staff is clearly defined and they are aware of it. Staff vaccination is routinely done. Temperature as chart is being changed from 8 hourly to 4 hourly. Humidity record and authorization of critical instrument is given to a single person, so a single lab should not be there. Component quality is maintained daily, weekly, monthly. Routine air and water culture is being done in our blood center. These indicators are mandatory to achieve NABH, and we used to send every month to State Drug Control Authority. We are registered with CMC EQUAS and Hemovigilance Program of India. We prepare training schedule for 1 year of all our staffs, and material safety data sheet and emergency code is being defined and staffs are duly trained. This picture shows the training of staffs. Our routine activities includes regular CME, donor education program, blood donation camps. Again, we did a follow-up audit and we find out that our statistics match with the national statistics. These are my references. So we went for a NABH assessment and we came with flying colors. This is our certificate, and we can say proudly that we are the first institute in entire Chhattisgarh and among 100 top blood center institute to achieve this success, and first in cell chain of hospitals. The cycle will continue. It was a transformative journey. With structured approach and commitment, we can achieve it. And this lovely sweet picture shows my lovely family with our ex-ED donating the blood. Thank you, everyone.
Thank you, Dr. Deepak. My query is, whatever you have done, this is the process you followed for the accreditation of NABH. Okay. But in your quality management, what was your baseline and how you improved to a certain level, that is not reflected, number one. Number two, you have shared the temperature management of the blood center. Earlier you were taking 8 hourly, then 4 hourly. But I think it is a continuous monitoring of the temperature of any blood center.
Sir, so in CDSU, actually 8 hours is recommended. But for NABH, you need to, temperature maintenance is 4 hourly is mandated. And continuous monitoring is being done by the in-house thermometer, sir. And the TQM, you are saying that you, sir, applied 3 point of care. Sir, TQM is essential. You can find out that in different studies is there. Outside India, they follow the TQM procedure to achieve the JCI accreditation also. So the same thing we are applying in Bhilai also, sir. But thing is, it is a newer thing which many are not aware that blood center can also apply the TQM process, sir.
Okay, now the process is okay. But what was your baseline before that application of these processes?
My baseline is, sir, PDCS.
And what was the improvement?
Sir, these are my improvement which I saw, sir. Sir, basically, in resource limited and industrial setup like us, sir, main is, sir, budget constraint, leadership commitment, and the in manpower who are involved in the process, they need to be committed. Because, sir, in a government-backed organization, I again tell you, in a government-backed organization, it is very difficult. Even if AIMS don't have NABS,
Just we
sir.
can sort it now. Any one question from the audience?
Congratulations for getting NABH for your hospital. Just one query that I had was, I believe you are from pathology?
Yes, sir.
Was pathology part of the scope of the assessment?
Sir, actually, I have done also 3 years residency in transfusion medicine, so I have quite an idea.
That is fine, sir. And again, congratulations on the NABH accreditation. I just wanted to know, in the assessment of NABH, was your pathology department part of the scope of the hospital?
Yes, sir. Thank you. Thank you for asking the question. Yes, sir. Each and individual staff of pathology, of management is a part, sir.
Okay.
Because
so
it is a continuous process. Sir.
Fine. So then my follow-up question would be, what is your quality assurance parameters? Do you have a tie-up with any hospital, any other national center which would give more credibility to your lab?
Yes, sir. Sir, I already shown the CMC EQUAS report, sir. External quality control report, sir. And we are continuously taking from all the certification of calibration from NABL lab, sir. That is from Delhi NABL lab, sir, which I already showed, sir.
No, for quality assurance, you need to send some of your sample. Anyway,
yes, sir.
Fine.
That is I am telling, sir. CMC EQUAS, sir. That is external quality control only, sir.
I think last question, Dr. Jayanta.
Thank you for giving me this opportunity to ask. Before, just see, TQM, matlab you do an intervention, you study some gaps, do an intervention, then follow up, and you see what is the result. So just before initiation of NABH steps, before जब आया thought कि NABH करना चाहिए, that means there were certain problems in the department which were going on. To then only that was a stimulus to go for NABH, and then after this implementation, most probably it was entry level certification.
No, sir. It is a fully accredited.
So when did you get the certificate?
Last year, sir.
Last year. So after that, this 1 year, वही पैरामीटर्स को एक बार कंपेयर कर देता है कि व्हाट आर द इम्प्लीमेंट्स है, उसका कोई स्कोरिंग पैटर्न कर देता है तो बहुत अच्छा होता है.
Sir, actually we got in October only, and it's not 1 year.
So I think the message has been passed. So thank you for the nice topic. Thank you, Dr.
Thank you. Dr. Tripti Chandra for the next paper from Bokaro.
For professionals, quality may have something to do with techno-professional aspect. But for the client, quality is their own level of personal satisfaction and perspective. Keeping this in mind, hanging my apron on the wall and coming out from the side doors of my own specialty, I am here with securing the healing space, RFID and TQM synergy for visitor access control in Bokaro General Hospital. Good afternoon, Chairperson, judges and everyone present here. Our hospital was facing unique set of challenges like security breaches, infection spread, operational burdens and financial losses. Due to overcrowding of visitors, unsafe and unhygienic practices along with rising thefts and conflict. These were generated due to ineffective manual monitoring and no automation along with liberal and deviating entry policies. According to PDCA cycle, we started working on our issue and the problem was impacting on various dimensions like patient privacy, security breaches, visitor-associated infection, man-hour loss along with thefts. The Ishikawa diagram showed us various contributing factors in our existing problem. Along with YY analysis, we got manual monitoring with no automation and no tracking system as the root cause. The manual control system, along with traditional security measures and multiple entry points, has cumulatively contributed 73.7% in our existing problem. So, with the aim and objective of controlling visitors' access, developing a proper access control mechanism, reducing VAI, and upgrading the security and patient satisfaction index, we have started exploring various solutions and their feasibility. And finally, we got RFID-based access with centralized surveillance as the most viable option. The solution we opted for was radio frequency identification access control system having P-type automated gates with real-time tracking and contactless operations with CCTV integration. The implementation was done under 4 phases within the time frame of 6 months The phase 1 was the deployment of hardware along with software integration and the centralized surveillance. Phase 2 was training of all the relevant stakeholders. Phase 3 was pilot analysis, where we issued RFID cards and high-risk period coverage were taken into consideration with SOP development. Then the final implementation with consistent enforcement, policy compliance monitoring, and continuous feedback and optimization. During the pilot study or the analysis, many problems were popped up in front of us, like loss of cards, resistance from the stakeholders towards the new system, technical issues, emergency access, and unawareness amongst the patient's attendants. But we were ready with the smart solutions, like refundable deposits, meeting and interactive sessions with various stakeholders to convey them about the benefit of the new system. Interdepartmental interactions were done for resolving technical issues. Temporary cards were issued for the emergency access, and for the public awareness and smooth shift in their mindset and culture, we installed multiple banners and guidelines. We retuned our SOP under various categories like visitors entry, RFID card usage, emergency access, and public awareness and training. The result of whole exercise was very significant, with a reduction of visitor-related complaints from 18 to 3, 0 breaches, VAI was reduced to 12, and man-hour loss were decreased to 2, with elimination of theft. PSI, although reduced during the implementation, but post-project we could achieve 87% of patient satisfaction index. With reduction in the deployment of home guards, we could save 4,50,000 rupees per month, in addition to reduction in infection control expenditures, enhanced protection of assets, and better utilization of hospital resources. In terms of clinical, operational, and organizational benefits, we could provide enhanced environment for recovery to the patients, reduce administrative burden, and resolution of conflicts. Last but not the least, with this project, we could align with the sales vision of safety, cost effectiveness, quality improvement with excellence. If we sum up our benefits after this project, we can very well say that implementation of RFID access gates in synergy with TQM principles has transformed theoretical framework into a measurable hospital services enhancement. To conclude, I would say crises and deadlocks are opportunities that force us to think out of the box and find new solutions, like we introduced and adopted RFID-based access control system in our hospital. Thank you so much.
Thank you, Dr. Tripti. Now, the subject is open for discussion.
Good afternoon. Very good initiative. We also have a similar system in our place. So just a few queries. One is if the system malfunctions, how do you take care of it? The other thing is the RFID that you're talking about is given to the visitors also? The red card that you were talking, that's given to the visitors also?
Visitors also on the emergency basis.
RFID card is given to the visitors?
No, it's a red card, temporary cards we have introduced, not the proper RFID cards. Only one RFID
so that
card
would not work. So that would not work on the RFID.
No, the emergency access, for the emergency access we have.
So you have a
maintained
separate
SOP. Yeah.
Okay.
We have developed a separate SOP for those kinds of situations.
So if like coming back to my original question, if there is a malfunction, how do you?
So firstly, we do have, I can say 24/7 backup of a technical staff for that. That is the civil and electrical department within the hospital. If we talk about the system only, the RFID system in per se, so we can allow.
So ma'am, you are running two parallel systems. That is what you're saying,
yes,
right? Because this is not totally. Two
parallel systems in times of emergencies. We do deploy home guards there for the further monitoring in the case of such kind of situations, sir.
No, you
And
have
somewhere you mentioned about
50% reduction.
improvement in
Thank you. Next, any other question?
You have multiple ports, you know, it's a horizontal expansion of the hospital.
Yeah.
We do not have a vertical.
Correct.
So you don't have single entry points, you have multiple entry points. So have you put RFIDs in all the entry points?
Ma'am, because placing, we have just evaluated the most those areas in
Which
the
are most
building which
crowded.
are most which has
More
the maximum
visitors.
footfall from which gate, and
That
by
becomes a
placing
problem.
the RFID gates on those places, we could control many of the sub entry points further. Yeah.
Thank you. We can conclude the topic.
Yeah. Thank you so much, everyone.
Now we have the last speaker, Dr. Navanil Roy from Rourkela.
Just a small announcement. Small announcement. As we are running late today by half an hour, so shall we curtail the lunch for 30 minutes? Because 2 o'clock sharp there will be webinar on tumor mode, which I think Dr. Singh asked for in a, what do you call, one of the guest speakers who are talking about that how the cancer should be evaluated and after the diagnosis, there should be a tumor board. So there will be an interesting session of tumor board online from Ruby Hospital from 2 to 2:30. So let's cooperate all of us and have an early lunch, short lunch, 1:30 to 2 p.m. Thank you. Thank
Sir,
you.
audience is full cooperative. They can curtail it to dinner, I think. Thank you, sir. Thank you. We will.
Good afternoon to my respected judges, esteemed chairpersons, and President, one and all present here. Implementation of TQM in hospital inventory management is the topic of my TQM paper. So coming to the introduction, in order. Good afternoon to one and all. Implementation of TQM in hospital inventory management is the TQM topic. So coming to the introduction, in order to deliver quality care to patients, we need a highly efficient central medical store system in all hospitals. Basically, we see this type of problems: stock out, drug expiry, and customer satisfaction. Hence, we planned this TQM paper on hospital inventory management. According to the we planned it according to the PDCA cycle, plan, do, check and act, and analyze these modifiable and non-modifiable factors. This is lack of knowledge regarding the procurement process, lack of communication between the staff, and a poor feedback tool. The aim of this study is to measure the outcome of TQM practices in 3 core performance metrics in store of our hospital. The 3 core performance metrics are the stock out rate, the material wastage, and the customer satisfaction. So what methods we applied? We identified the factors using the nominal group technique. Majorly the problems were communication failure, lack of knowledge in procurements, and delay in generating the purchase requisition, that is the PR. The total study period was of 7 months. That is the problem we identified from January to May 25. We intervened, strictly monitored and trained our staff from June and July 25, and we analyzed and observed the results in August to December 25. So the following steps were taken to improve the quality. Stock of the expected use of medicines was planned for 18 months. Requisition was generated when stock was in hand for 9 months. This is also known as reorder level. Extensive training of the staff was done in this regard. Now the most important is our in-house RSP software, T-code ZMed REQIGH. Every store consumption pattern is being recorded. A pop-up message comes up, material at reorder level, please process. To prevent the expiry of the drugs, the following steps were taken. A guarantee certificate was mandatory for all items below 80% of the shelf life at the time of receiving the items, implementing free of cost replacement of the supplied quantity from the supplier. And with the help of our IT department, a system was developed to alert the clinician regarding the use of drugs before 6 months. So this was the training process undertaken in our hospital. Training was given to the frontline persons for 15 hours on VED, ABC, FSN analysis, including racking, indexing and judicious use of drug formulary. VED is vital, essential, desirable drugs. ABC is the consumption pattern and FSN is the fast moving, slow moving and non-moving drugs. So to assess the proper feedback, 10 number of people were randomly selected from each category of doctors, nursing staff, laboratory technician and store persons, and the satisfaction score was assessed using the Likert scaling system. It was a 7-point scale from very dissatisfied to very satisfied. Coming to the results, it is very evident from this table that before implementing the TQM and after implementing the TQM, there was a significant change in the stock out rate, where the p-value is 0.002. The drug expiry also significantly changed from the before implementing the TQM and after implementing the TQM. The satisfaction score of our internal stakeholders also changed from very dissatisfied to very satisfied before implementing and after implementing the TQM. So to summarize, the availability of routine items improved to 95% in our central medical store. Expiry of the drugs reduced from 10% to 6% in the study period. Awareness among the staff regarding the availability and expiry of medicines improved significantly. Internal stakeholder satisfaction level also increased significantly. So to conclude, TQM guided steps, if implemented satisfactorily in stores of our hospital, it helps to improve the stock out rates, customer satisfaction and decreases drug expiry rate. Thank you. Jai Jagannath.
Thank you for nice presentation. So what are the areas you intervened which were lacking in the before the implementation of this quality management? What are the factors which has improved to availability of the 95%?
Sir, thank you for the question, sir. Majorly, it was the lack of knowledge about the proper procurement process, sir. And this was leading to the stock out rate. And drug expiry is a very common problem where the use of that certain drugs is not being done properly. So we took these two main parameters which has helped us to improve our stock position and drug expiry position.
Okay. Any questions from audience?
Good afternoon. I'm Dr. Pooja Syal. I wanted to know, like you say you take a guarantee certificate from the party.
Yes.
So how do you actually maintain that those parties, like those who are supplying materials less than shelf life 80%, so how do you follow up? Because everybody gives a guarantee certificate, there's no doubt. But how at your end do you follow it up?
Ma'am, to be more sure, we take two guarantee certificates, one from the original manufacturer and one from the supplier. So we follow up with the supplier who follow ups with the original manufacturer, and that is how we take the free replacement.
No, so what I'm trying to say, so you have a register where you maintain that these are the drugs which are shelf life, because it is very difficult. There's so many items coming in the hospital. So how do you follow up?
Yes, we have a register of drug expiry in our all locations, ma'am. We have 5 locations, location 1, 2, 3, 4, 5. Out of that, 3 are of medicine and 2 are of consumables and equipments. We have a register in every store location where we see the drug expiry. Every 15 days we check the expiry rate.
Okay, thank you.
I think this was the last presentation, so we finished our TQM paper.
Thank you very much, sir. I call Dr. Rajranjan Kumar, sir, to felicitate our chairperson.
Sir, I think this is the felicitation.
Thank you, Karunami, sir. Thank you, madam. Thank you, sir, for chairing this session. And now we will join for lunch. Ruby, sir.